Uh, a very good evening to all. So welcome back for our second day of webinar on female genital system. So after yesterday's illuminating talks of the FGS by the true legends in their field, we ensure yet another dynamic sessions. So let's start the first talk of the day. To introduce the speaker, I invite Dr. Rajan G, President, IAPM Kerala Chapter. Over to you, sir.
Okay, thank you, Annie. This is the second day of the webinar. We are starting by 5:30. There are 4 lectures today. The first is on cervical pathology, cervical cytology, and followed by borderline tumors of the ovary, then carcinoma ovary, and finally carcinoma cervix, the recent updates. Okay, you know that cervical cytology reporting is a routine work for any practicing pathologist, whether they are in a lab or in a teaching hospital or in a super specialty hospital. The difference is whether they are practicing reporting on a conventional smear or a liquid-based cytology. But as you know, there are many pitfalls in reporting cervical smear because this organ, they can shed their usual lining, lot of metaplastic changes can occur, lot of inflammation can occur, lot of dysplasia can occur. So always it is a challenging thing to report on a cervical smear. So let us see what are the common pitfalls and how can you correct these pitfalls. Today we have an expert in this scenario, Dr. Michael. He is a senior consultant pathologist working in KK Women and Children Hospital, Singapore. So he has a vast experience in cervical cytology reporting. And sir, he already communicated that don't tell his CV too much. So here are a lot of publications to his credit, and a lot of articles are published in in-depth journals. And this is a recorded version, and because he's out of station now, he's actually difficult to present us live now. He has gone to some other country. So we recorded the audio video and a good quality audio video. And I think we can start now.
Hello everyone, greetings from Singapore. I'm Mihir Guri. I'm a consultant at the KK Women and Children's Hospital at Singapore. So today the topic I've been asked to talk on is diagnostic pitfalls in gynae cytology. So let me begin with some very basic stuff, which is how do we call smears unsatisfactory? So smears could be unsatisfactory. Either you have less material, and how do you assess that? You usually go on a low power view and you try to see whether about 20 cells per field. If they are less, then usually it is a unsatisfactory sample. However, even if there is a few atypical cells in the smear, irrespective of its cellularity, cannot be called inadequate. Then of course the smear may be inadequate because whilst we are trying to assess the transformation zone, if the smear consists predominantly only of endocervical cells, then it is deemed unsatisfactory, unless of course the exception is that you are following up a patient for a glandular abnormality. The smear may completely be filled with inflammatory cells, which makes seeing the cells from the transformation zone very difficult. Then the smear is inadequate. When the cell has no cellularity or single cells here and there is inadequate. Of course, sometimes there may be contaminated gel, contaminated gauze pieces, or tampon pieces, which all could make the interpretation difficult, and that smear is unsatisfactory. Then let's see some normal components. So of course, besides intermediate, superficial, and basal and parabasal cells, you get clusters of cells in cervical smears. They may look flat honeycomb sheets of endocervical cells in this view, or in a perpendicular view can look like a picket fence of endocervical cells, both of which are normal appearances, and three-dimensional clusters of endometrial cells. Then we have infections that, whilst is not what is necessary to pick up in a screening smear, but if the infections are present, we need to report them. So this one is what we all can recognize as Trichomonas Multinucleation and margination of chromatin is seen in herpes. Patients with IUCD with actinomyces. Presence of candida giving the very classical inflammatory background with perinuclear halos. Then, of course, HPV infection, which is characterized by the coilocytic cell, polka dot cell, could be binucleation and nuclear membrane abnormalities. Then we come to grades of Discoliosis. Now, depending on which system you use, the British or the Bethesda. So these cells, as we see, have a lot of cytoplasm, but the nucleus is irregular. The nuclear chromatin is a bit irregular. There's clumping. And if you see that the nucleus to cytoplasm ratio, there's more of cytoplasm than the nucleus, and the nucleus enlargement is less than 1/3 of the total cell diameter. So this is low-grade dyskaryosis. You can call it low cell, you can call it mild dyskaryosis, all are equivalent terminologies. Then we come to high-grade dyskaryosis, which includes both moderate and severe dyskaryosis, in which the cells have a higher NC ratio. If you see the chromatin is a bit clumped, the nuclear membrane will be abnormal, and you see that the hyperchromasia of the nucleus is much higher than the hyperchromasia of the surrounding superficial or intermediate cell. Similar cells here, it almost looks like a raisin or a dried grape with these very convoluted nuclei. So that's quite classical of high-grade dyskaryosis. Then, of course, what we don't want to see in a screen population is the presence of these tadpole cells and spindle cells with tumor diathesis in the background, which is an indicator of squamous cell carcinoma. The other entity that is now being seen commoner is endocervical or extracervical glandular neoplasia. And there you have clusters of cells. The cells tend to be columnar. There appears to be feathering where the cells fall off. There is overlapping of the nuclei. The nuclei, if you see compared to a squamous cell or squamous abnormality, the nuclei tend to be quite oval. The nuclear membrane chromatin, the nuclear chromatin appears to be quite stippled, but the stippling is larger than what you see with stippling with normal endocervical cells. So this is glandular neoplasia, called pueriglandular neoplasia in the British system of classification. In the Bethesda, it is called adrenal carcinoma in situ. Then, of course, whilst it may be difficult sometimes to distinguish between adenocarcinoma and CGIN or adenocarcinoma in situ, sometimes smears may show dissociated single columnar type cells with background inflammation, prominent nuclei within the cells, and necrosis in the background. So there you can suggest a diagnosis of adenocarcinoma. Of course, that is what is seen usually in cervical adenocarcinomas. When you get an adenocarcinoma which is not cervical in origin, the cells tend to ball up. They could be, if they are arising from the endometrium, then the cells tend to ball up like endometrial cells. But then these cells have large nuclei. They can tend to have very prominent pink eosinophilic nucleoli. Of course, you can sometimes get necrosis. Sometimes the cells ball up and the nuclear chromatin is quite dense, and sometimes you have very large pleomorphic nuclei. In those cases, sometimes you can suggest extracervical and most likely serous subtype of the tumor, who may be arising from the endometrium or from the ovary. So then we have seen what is inadequate smears, what is normally expected, and sometimes what infections you might encounter, and the usual reporting categories. So then what is new since, like when I was a student, when what was there in cervical surgery, what has it become now? So from then on, from conventional smears, we have moved to liquid-based cytology. So either it could be SurePath or ThinPrep, whatever your institute practices. Then came HPV vaccination. Then it followed on by reflex testing for low-grade abnormalities and post-treatment. And then, of course, now the latest is primary HPV testing. So whilst we were initially used, so I have seen the whole spectrum. We have seen smears where we had slides containing a lot of materials spread on a slide stained with PAP. Then either if you're used to a slightly larger round surface area to screen like in ThinPrep, or in SurePrep the button is slightly smaller. Now, of course, the difference between these two is ThinPrep tends to be a monolayer sheet of cells, while SurePath can have cells in more than one layers. Both have their advantages and disadvantages. Okay, then let me go through diagnostic pitfalls in tiny cytology. Okay, now this is a case who is a female of 45 who has a wart smear. What I have not told you here is this patient was operated for stage 3B endometrial carcinoma a few months ago. And so you're seeing these cells which are quite large. The nuclei are large. There is nuclear hyperchromasia. So all the features that you associate with Discoliosis are there. The cells have some nuclear vacuolation. So you might be tended to call this. So depending on the appearances here, this cell probably is moderate, this cell is mild. So you might think of Discoliosis, but then the history is given, and you also know it's a wart smear. So of course, the patient has had something in the past which has been excised. So most likely hysterectomy in the past. So when you have these features, and if you very closely examine the cells, you see that the nuclear membrane is not very clearly visible. The nuclear chromatin appears a bit smudged. Then there is some cells which appear to degenerate. There's cytoplasmic vacuolation. So these are very typical features of post-radiation dysplasia. Sorry, post-radiation cells in patients who have had previous surgery for endometrial or cervical cancer. So again, you can see this ink dot-like chromatin. There's inflammation. There's variation in nuclear shapes and sizes. There is background appears with some inflammation. And very obvious, there's some multinucleation and very obvious ballooned up cytoplasmic vacuolation in the cells. So this is radiation effect. So do we routinely perform post-radiation smears? No. So this is not routinely advised to have screening of recurrence through pap smear. The reason is because it is very difficult to interpret. And depending on the radiation change, so usually acute or chronic, we both have problems interpreting because they can both be mistaken for dysplastic cells. The history is sometimes very crucial because it tells you that this patient has had a hysterectomy for endometrial cervical cancer and has been given radiotherapy. And hence, then with that information, you can probably make the diagnosis quite easily. Cells sometimes can truly mimic dysplasia. However, because of course you can get recurrence in the wall. But these cells, when you are want to diagnose recurrence in the wall, the cells, the dysplasia should be, the threshold should be quite high, and the cells should be truly dysplastic, and they should have really abnormal nuclear chromatin compared to the background cells which are showing radiation change. As I said to you, cytology is not very sensitive and should not be the method used by preference to diagnose recurrence. What is then the preferred method? The preferred method, of course, is clinical examination, biopsying that area, which then confirms whether there's recurrence or not. Case 2 is a 49-year-old female, and you see that the smear is quite well estrogenized. There's inflammation, and there are some cells with slightly increased NC ratio. There is the nuclear hyperchromasia is there, but nothing nothing that is glaring at you. So this was called because of the slight increase as ASCLO, or some people might call it ascus, some people might call it borderline. The biopsy then just showed dense chronic cervicitis with reactive changes in the overlying epithelium. And then how do you then distinguish a low-grade lesion from reactive change or borderline from Discoliosis? So you look at the nuclear membrane. So in SurePath and ThinPrep, because the cells are within a preservative, the nuclear details are quite well preserved. The chromatin is also quite well preserved. So you tend to assess the slides based on nuclear membrane abnormalities and chromatin abnormalities. Both of them should be present to call a cell dysplastic or dyskaryotic. There should be hyperchromasia. When you see these cells, you should make sure that these cells are showing these features in the absence of background inflammation. So this inflammation is obscuring these cells, and the features are seen in the presence of dense inflammation. Go around and find cells which do not show the inflammation and whether they truly show dyskaryotic features. And of course, in low-grade lesions, if your institute follows reflex testing, then you do Hpv triage and look for the high-risk Hpv. The ones with high-risk Hpv will be referred to colposcopy. The ones which do not will be sent to normal recall. Case 3 is a 25-year-old girl who had an LNP 16 days ago, and again you see that, so you see this strand which is candida, then you have cells which are intermediate or superficial cells with slightly enlarged hyperchromatic nuclei scattered around, okay? So you're thinking, could this just be candida with probably low-grade changes, or is it reactive changes because of the candida? So this is what it was called. It was called low-grade with candida. The biopsy, however, which was done, shows this full thickness dysplasia, which is in keeping with CIN3. And then when you go back and look at the smear, you see that there are scattered cells which have a high NC ratio, clumped chromatin, irregular nuclear membrane. So there are few, but they are present within the smear. So this smear was undercalled in the index interpretation. So what are the learning points here? So when you see a smear, we are always told that, especially when you screen by the thin prep, first you concentrate on the cells and then you rapidly screen it again to look in between the cells. And usually these smaller cells that you tend to miss are found in between the larger cells with the mild Discoliosis or the low-grade abnormality. So these cells can be lurking in between the larger superficial cells or intermediate cells. They can be in small clusters. They have nuclei which are convoluted nuclear membrane that is abnormal, chromatin that is abnormal. Remember that besides if we see one pathology, there can always be a second pathology. So in discordant cases like this, always go back and review the cytology. Of course, people become very clever, and especially when you are very clever when you review someone else's cytology. But of course, it's a good learning exercise. Always go back and review. Then sometimes you can get very few cells, and this is called sparse cells. And usually when the smear has less than 200 cells, you might miss the few cells. Then you have small cell dyskaryosis, where the cells are very small and they can almost look like lymphocytes and can misinterpret it as follicular cervicitis. Pale cell dyskaryosis, as shows here, is usually an artifact because of thin prep, usually seen in thin prep smears. And what happens is the nuclear chromatin goes and sticks to the nuclear membrane, and then there's clearing of the nucleoplasm. However, if you still see the nuclear membrane is irregular, so hence you should be able to pick up. And whilst there may be few cells showing this, there will be other cells showing conventional dyskaryosis. And then if in doubt, of course, you can call this borderline cell, and then you do HPV testing to look for the high risk HPV. Case number 4 is a 53-year-old lady who has postmenopausal bleeding, and again here you have quite a mature smear, and then there's the smaller cells which look to be parabasal basal with hyperchromatic nuclei, some inflammation in the background. But the cells, because they were small and this slightly increased NC ratio, in the presence of some inflammation, this was deemed to represent borderline high grade, cannot be excluded, or the Bethesda as ASH. And the biopsy, then of course, if you see here, you see that there is no dysplasia here, it's all atrophy. And this is all basal HPI in an atrophic patient. So the pitfalls here as a parabasal and basal cells, because their NC ratio is of course higher and the nucleus tends to be slightly more darkly stained, you may misinterpret these as dyskaryotic cells. And because they are in smaller cells, by default, this becomes high-grade dyskaryosis. But then even in these cells, you need to look for the nuclear membrane and chromatin abnormalities. And in doubt, sometimes if the smear is extremely atrophic, you can request for application of topical estrogen to mature the smear and repeat the smear in a few weeks or in 6 months' time. And then you look for the cells if they're truly present and are they truly dysplastic in the repeat smear. So this is a 35-year-old lady who has a postpartum smear, and even here you can see that these, of course, is a metaplastic cell. Compare this to this one where the NC ratio is high, the nuclear chromatin is darker as compared to this cell in the background here, and the nuclear, there's some nuclear membrane abnormalities, but the cells are few, hence this was called ASH. And what does the biopsy then show? The biopsy shows that there are crypts which is involved by squamous lesion. There's loss of differentiation within the squamous epithelium, so this is high-grade dysplasia involving crypts. So crypt involvement can occur in CIN. Crypt involvement in the smear looks like clustered hyperchromatic crowded clusters of cells. Is it important to say that there's crypt involvement in the smear? Yes, because if you tell the clinician that there is crypt involvement, they tend to do a deeper cone so that they manage to get free margins, because for them they cannot actually see the endocervical canal very clearly on colposcopy. And then always remember that when you have CGIN or high-grade lesion or AIS, there can be a concurrent or concomitant high-grade squamous lesion in about 50% of the cases. Okay, then this is case 6, which is a 30-year-old girl with a history of CIN3, which has been treated by bone biopsy, and this is a follow-up. And here also you see that in the smear, there were areas in which the cells were crowded together. They formed clusters, they were hyperchromatic. And here, of course, when you look at it, it has all the typical features that you associate with Discoliosis. This is within a small cell with a high NC ratio. So this was, but the cells were very few, hence the pathologists at that point thought that cannot confidently call it CIN3, so called it ASCH. And this is a biopsy which of course confirms that there is a high-grade lesion there, CIN3. So remember that the pitfalls in all these cases could be that the patient, if the smear is showing postpartum and atrophy, both of these usually show similar features. And I said to you, in these cases, if there's doubt, you can repeat the smear of a topical distortion therapy to mature the smear. Remember that following treatment, especially following a bone biopsy, you tend to get lower uterine, or you can get tuber-endometrial metaplasia, and these cells can look quite scary because tubal cells looks quite scary even on the smear. But as long as you can demonstrate cilia, then you're quite reassured. I mean, of course, I have to say that there's a very, very, very rare form of ciliated adrenal carcinoma of the cervix, which can be missed if you just rely on cilia being an indicator for benign cells, but that's extraordinarily rare. When you have post-treatment and there's a cone, following a cone, there can be endometrial cells that can be shed in the smear, and those, because they're crowded, can mimic. You might be fooled to call these cells dyskaryotic. When in doubt, as I said, if you have the technology, you can do Hpv triage, or you can do Hpv as a test of cure. So remember that ASCH in pregnant women is less likely to be associated with underlying squamous lesion or CIN in the general population. In this context, a positive HPV test is more important than a negative test. Remember, like I said to you, in atrophic and radiation smear evaluation in pregnant postpartum state is challenging. And in that state, conservative management, if the previous diagnosis is ASCH, is preferred, and usually HPV test may be a better option than going inside and trying to get a cone or trying something more invasive. And routinely you would do a postmortem pap test, and then 2-year follow-up is advised to pick up any significant lesions. So now we go to slightly more sinister lesions, and this lesion I've shown you the picture before. Is a case where there's a lot of cells. The cells are dispersed. There are spindle cells, tadpole cells. They're cells with high NC ratio. There are cells in clusters, and cells which are singly dispersed with having also tadpole, spindle. So you're thinking of squamous cell carcinoma here. So here the cells have a typical hemorrhagic diathesis with this necrosis and inflammatory background. Then tadpole, spindle, all things that you expect to see in SCC. Okay, so the whole range is there. So this, in the UK classification, would be called query SCC, or Bethesda, if you want to call it, is called as squamous cell carcinoma. And then, of course, you know the histology of squamous cell carcinoma will be quite varied, and so can be the cytology. So you can have cells where there's very obvious keratinization, cells in which there's not keratinization is not very obvious and they look very basaloid. So those type of cells would also be present in the smear. So everywhere you may not get the very classic appearance of keratinized atypical cells. Sometimes you get cells that are quite poorly differentiated but showing all the same features, and sometimes it may be very difficult to distinguish whether this truly represents squamous cell carcinoma or adenocarcinoma, which is poorly differentiated, in which case the Bethesda gives you that option of calling it carcinoma NOS, or and the UK system, even if you call it query SCC or query glandular, it really doesn't matter because the management is the same, and screening is done for that. It is for managing the patients. Okay, this is another case where you see, of course, these are very abnormal cells. They're singly scattered, they're spindle cells, they're larger cells, there's some clearing in the cytoplasm here. So this was called query SCC. And as you see here, it was an SCC, but in the SCC there were areas of clear cell chain, which is because of glycogenation and not because of clear cell carcinoma. So how does SCC look in liquid-based preparations? So because of the filtration technique that is used in liquid-based preparations, there is less hemorrhagic diathesis as compared to conventional smears. So you can still have the very classic spindle cells, tadpole cells, and atypical keratinized cells. Remember that not all SCC can have classic appearances. As I said, you can have non-keratinizing and SCC with clear cell change. In a very well screened population, the stage of the SCC that you are going to pick up is going to be low stage. So you may not get the very classic features of hemorrhagic diathesis. And the type of tumors that I tend to get usually is either micro-invasive, early stromal invasive type of carcinomas. Now this is a 41-year-old, and you see that the smear was done as part of routine screening, and you have a cluster of cells here. There's some overlapping, there is some crowding. There's even a low power here they are seen. So this was deemed, and the pathologist at that point thought that because of the inflammation and the high grade cells, this probably could represent severe discoliosis and possibility that there's invasion. And if you see the biopsy, that's quite inflamed, but then there's a script involved by dysplastic squamous epithelium, which is full thickness dysplasia. So the biopsy showed CIN3 but no invasion. So what was the reason that the smear was showing features that could be suggestive of invasive carcinoma? And if you have such a case, what do you do? So this, when you call it severe query invasive carcinoma, and the British classification is same as when you either are suspicious of invasive or they have features very typical of invasive carcinoma. So in real life, if the biopsy does not show, you try to do deeper levels. And then remember that sometimes keratinizing CIN3 can have atypical keratinized cells, but usually does not have associated hemorrhagic diathesis. So hence you can try to differentiate one from the other. This is a 40-year-old lady, and the smear showed these clusters of highly atypical cells. They don't look typically squamous, am I right? You have a feeling that this probably are glandular cells. There is some cell-to-cell arrangement. There are, however, some cells which look a bit metaplastic squamous with enlarged hyperchromatic nuclei. So this was called query in SCC. They said there was a concurrent glandular lesion and was sent off to colposcopy. And you see this, the biopsy is actually quite poorly differentiated. And if you could, however, can imagine that these are small glands with these gland spaces, so it possibly is an adenocarcinoma. It also has areas in which there is keratinization or there's evidence of squamous differentiation. So this is called a poorly differentiated adenosquamous carcinoma. A difficult diagnosis, a rare diagnosis. If you miss one of the other components, is okay because the patient has been sent to urgent colposcopy, so they will pick it up. This patient, on the other hand, has a severely abnormal smear with cells which look almost like tadpole cells, with highly abnormal nucleochromatin. There's diathesis in the background. Cells, if you examine them very closely, the nuclei tend to be slightly oval and the nuclear chromatin is appears slightly quite stippled. So you're thinking, what? Very invasive SCC? Because of stippled chromatin, what else could it be? So this is a small cell carcinoma of the cervix. And it was positive for chromogranin and cyanoprophysin. Then we come to the new thing now, which is being increasingly seen, are glandular lesions. So if you see the SEER data from recently, it says that there has been a gradual increase over the past 3 decades of glandular lesions, from 12% in the 80s to almost now 34%. So almost a 3-fold increase. Now, what is the reason for this increase? So it may be because in a screened population, there's decrease in squamous carcinoma as a result of screening. It could also be that there's increased glandular abnormalities seen because of increased hormone use, and also because we're able to pick up these lesions because of sampling techniques can sample the endocervical canal more accurately. Cervical adenocarcinoma, as opposed to squamous cell carcinoma, tends to occur in slightly more younger females. These females tend to be of higher socioeconomic status, tend to be slightly more highly educated, come from higher incomes, and there appears to be slightly less linkage to early sexual intercourse and smoking, and these are all factors which are different from what is seen in squamous cell carcinomas of the cervix. They tend to be largely like squamous cell carcinomas, predominantly HPV related. The majority of them are high risk HPV 18. The remaining small minority are 16 and 18 associated, 45 high risk HPV positive. And then I said to you previously, 50% of the endocervical tumors can have a coexistent squamous lesion, so always look for it. Remember that glandular lesions, especially the pre-invasive ones, may reside higher up in the endocervical canal, hence they may be missed on colposcopy. The false negative rate of a smear picking up these cells is almost up to 50%. Cytology is slightly less sensitive for glandular lesions compared to squamous, but as your experience and training improves, you are able to pick them up. HPV testing certainly has an important role in improving detection of endocervical neoplasia. However, remember that they are non-HPV related endocervical carcinomas, and if you only use HPV testing, then you might miss these. They are very small percentage, but still you might miss these. And hence there is a separate lobby that strongly recommends that there may be benefit in should not be contesting, it should be co-testing and or interval cytology alone and not relying only on HPV testing. So then let's go on to the spectrum of glandular lesions. So this is a cluster of atypical cells. The cells appear to be quite slightly columnar. There is polarization, so nucleus at one edge, cytoplasm at the other. So you're thinking of glandular here. Again here, there is columnar orientation to the cells. There are some singly scattered cells which are abnormal. And then of course here we have the classic features that you associated with endocervical Seagen, high-grade Seagen, or periglandular neoplasia, where there is clustering, there is overlapping, you see mitoses, okay, the mitoses here, there's feathering, and there are gland spaces. Okay, so all the features very typical of endocervical cervical adrenal carcinoma. This is periglandular neoplasia, endocervical or AIS. And then the biopsy, of course, confirms this. So these are glands showing high-grade Seagen. Another smear, again clusters of atypical cells. You see the cells, there's overlapping, there's crowding, there are mitoses, there are gland openings. So they are again thinking of glandular neoplasia, correct? But the cells were very few, and hence these were called borderline changes in glandular cells. What is the recommendation for these? Of course, these also go for HPV testing. In this case, the biopsy doesn't confirm the presence of an adenocarcinoma in situ, an invasive adenocarcinoma. This is another lady, 52-year-old. LMT was 2 weeks ago, and HPV testing was found to be HPV high risk 18 positive. Again, clusters of cells overlapping, some inflammation, some background lightly dirty. Then some multinucleate cell is there, but again these cells tend to be crowded. There is some inflammation though in these cells. So this was again called because of the inflammation and because all the features were not very classic that you see with classic endocervical lesions. This was called borderline endocervical cells. This is the biopsy which shows Seagen, and then there's an underlying invasive mucinous adenocarcinoma. Another smear which you are seeing is very typically a very classic typical keratinized cell which appears like a tadpole, then clusters of highly abnormal cells. So I think, oh, could it be squamous? Then occasionally you have these cells with slightly more clear cytoplasm. Okay. So I think, oh, could it be SCC? And because they are single scattered cells which with nucleus displaced, could this be a component of adenocarcinoma also within it? So this one was an adenocarcinoma, and it also had features where there was clear cell carcinoma within the biopsy. So mixed. Now this is a patient who has a previous abnormal smear. HPV high risk was not detected, and we have these cells which are quite polarized with nucleus at one edge. Nucleus appears quite bland looking, and if you see the borders at the top, they appear to be quite frayed. And then of course you have this very top on appearance as in these endometrial cells, but they're these background spindle cells. So this is like a low uterine segment sampling. But because at that point the reporting pathologist was carried away by the cells which I showed you previously and called as glandular cells, query borderline glandular cells. And the biopsy of course showed just cervicitis. So then if you look back carefully, you see that these actually are not crowded clusters of abnormal cells. These are just lower uterine segment sampling, and this you can see the cilia here. So this is a case of probably the patient has had some previous treatment, or this is a case in which a 2-point metaplasia with lower uterine segment sampling. So when you usually report something called as periglandular neoplasia, what you normally get following that diagnosis is endocervical and endometrial sampling, because the cells can arise in either of these places. Usually, when they do further investigations, there may be an underlying polyp which could explain the findings. There could be cervicitis. Sometimes IUCD can give rise to these changes. And sometimes, as I said to you, if the brush has gone higher up, you can get high script, which can mimic high-grade lesions or can mimic glandular lesions. In these cases, when the biopsy is not representative, of course, go back and review smears with the colposcopy MDT. This is another case in which the cells are seeing a clustering. There's some vacuolation of the cytoplasm. Here, these typically look like endometrial cells. This was called borderline endometrial cells because of the initial cluster that I showed you. On further examination, you saw that there was ectonomyces. So when you see ectonomyces, you think of IUCD, correct? And then remember that IUCD can also give rise to changes in the cells which can be worrying. So what are the type of changes you get? You can get endometrial cells which are out of cycle. You can get presence of ectonomyces. You can get bubblegum cells, which are endometrial cells, which cluster up together. And because they cluster and they're slightly hyperchromatic, you are worried about them. And sometimes you can get mild atypia within the endometrial cells itself, which might make you overcall these cells. There's another case in which there's clustered cells, probably a mitosis, but quite overlapping of the nuclei. This was again called because the cells are not, though that atypical, was called Aegis and endometrial cells. And then the biopsy shows complex atypical hyperplasia, which can very easily, because the features are very similar to grade 1 endometrial adrenal carcinoma on the smear. This is another cell where you have a lot of these three-dimensional clusters, and these cells which are called polybags or inflammatory cells clustered up together like this are on top of the cells. And then in other areas you see that they appear to be glandular, they appear to be endometrial with three-dimensional with the cells projecting out, the nuclei projecting out. There's some inflammation and the nuclei, though not very prominent, they are visible in some of the cells. So this was called, because there were a lot of these in the smear, were called adenocarcinoma endometrial type. And then of course the biopsy confirms that this endometrioid adenocarcinoma. This is an elderly lady with postmenopausal bleeding, which is what usually happens in this set of patients. And then here it's very classic cluster cells. There's a lot of hemorrhagic diathesis in the background. The cells, if you look at them, they look very, very, the nuclei are quite large and pleomorphic. They're clustered, there's overlapping. They don't look typically endocervical. They certainly do not look classic of endometrioid. So you're thinking whether it could be extracervical and could it represent something beyond just the classic endometrioid carcinomas. So this was at that point was called adenocarcinoma NOS because couldn't differentiate whether it was typically endocervical or extracervical. And then of course the histology confirms it's a high-grade serous carcinoma, which is reflected in the smear with the cells being so pleomorphic. And this is coming from the endometrium. Okay, another case in which again you have these clusters of cells, high NC ratio, some vacuolated cytoplasm, quite abnormal cells. Okay, so this was again called Aegis, and the reason this might, I mean, this on one view these may look, so you may wonder why this is not called adenocarcinoma, this is called borderline, because the number of cells might be quite few. So this was called atypical cells, endometrial cells, or again borderline endometrial, and here you actually have a diagnosis of triple MT on the histology. So can you make this diagnosis of triple MT on cytology? Well, it's difficult. So what we try to look for are multinucleate cells. In addition to the abnormal glandular cells that you're seeing, we look for isolated cells with cyanophilic cytoplasm, which can be representative of these atypical spindle or sarcomatous cells in the background. We look for cells, these cells that tend to have very hyperchromatic nuclei, prominent nucleoli, and usually the differential here in the smear would be adenosquamous carcinoma, like I showed you in the previous case. Now this case again, I mean, I think it doesn't take long to, these are clusters of what appears to be endometrial type cells. In the same smear, you had a lot of like hemorrhagic diatheses with tadpole cells, keratinized cells. Okay, a very obvious keratinized cells and diathesis background, which is dirty. So this was called as Aegis in endometrial cells, and keratinized squames were present. And what did the histology show? So histology showed that this was an endometrioid carcinoma in which there were features of extensive squamous differentiation or extensive squamous modular differentiation. So when you see endometrial cells in smear, look at the LMP and correlate. Usually endometrial cells after the age of 40 is usually considered abnormal. How many days do you allow endometrial cells, normal endometrial cells to be seen? So up to day 14 is okay. Beyond that is definitely abnormal. I mean, having said that, they should mention the LMP. Sometimes, many times, I have to say they do not mention the LMP. If you see endometrial cells, mention their presence. But remember that if there's IUCD, then your threshold to call something abnormal endometrial cells should be higher. In postmenopausal bleeding, the presence of endometrial cells warrants further gynae investigation. So whether you essentially do not see endometrial cells in a postmenopausal bleeding, or you see, they anyway will do further investigations. And remember, as I said to you, that usually in neoplastic endometrial pathology, the endometrial cells in smear tend to have very bright pink eosinophilic cytoplasm. Again, so there's a cluster, what appears to be endometrial cells or glandular cells, quite large. There are nuclei which appear prominent. Now, background, the dissociated cells. Yeah. Again, cells have some vacuolated cytoplasm, quite large, three-dimensional. So you're thinking, is it query and endometrial adenocarcinoma? Could it be extracervical carcinoma coming from elsewhere? And of course, the biopsy shows a high-grade carcinoma with clear cell features. Yeah. So there were mixed endometrial and clear cell features. Now we come to another important entity which has been increasingly recognized now. So this is a very classic history, watery discharge from the cervix. And you see that this is almost like a flat cluster or sheet of endocervical cells, very tiny prominent nucleoli. There's some pigment here at the apical part, but there's some overlapping of the cells. Okay, the nuclear membrane and all is not typically abnormal. Then again, almost look like endocervical cells. If you look carefully, however, there is some overlapping. So difficult diagnosis. If you compare that to normal endocervical cells, you'll say, what is the big difference? Well, there is some overlapping here, there is no overlapping here, but very subtle. The leap then showed what is this, which is a invasive carcinoma, well differentiated, which has this very typical vacuolated cytoplasm. So you know what I'm trying to show you. Again, yeah, very vacuolated cytoplasm. Okay, so what is this? So this is cervical adenocarcinoma. This is the gastric type of cervical adenocarcinoma, and we know this is not HPV dependent. So it's an HPV independent cervical adenocarcinoma. So adenocarcinomas can usually, while they are HPV related, there are a small subset of cervical cancers which are not HPV. Amongst them is gastric type. Besides, it's endometrioid, clear cell. Yeah, these are all not related to HPV. So they usually tend to have, so this variant, the gastric type, tends to have bland cytology as well as bland histology. The history is quite classical of watery discharge, and on examination, the cervix appears to have a barrel-shaped appearance. So this I'll just allow you to read later on when they send you the presentation, how to differentiate glandular lesions of the gastric type as opposed to the classic endocervical type. And on the top here, you have all the features that you see with gastric type, and below have the classic features I've shown you with endocervical type. And you can see that there are subtle differences. These tend to be quite more bland. Sometimes you can have goblet cells or vacuolation of the cytoplasm. And these ones you don't have a problem actually identifying the cells. So this is a 65-year-old lady with postmenopausal bleeding, and you see that there are clusters of cells which are atypical. There's polarization. You can almost see that there's a bit of palisading, and there's clustering here. Okay, then also overlapping oval nuclei, there's prominent nucleoli, dirty chromatin. So just now we spoke for 40 minutes on this, so this has to be glandular. This is adenocarcinoma. Fine, there's some cytoplasmic evacuation, so this could be still an adenocarcinoma coming from elsewhere, from the endometrium, maybe perhaps the ovary. So some might say, well, that could be clear cell change in a squamous cell carcinoma. And say some could know, well, this could represent, adenocarcinoma from the endocervix, or just I can't decide between the two sets, carcinoma NOS. Then they tell you, oh, actually this patient has a history of altered bowel habit. Then say, oh, then yes, and then probably this is metastases coming from the colon. So this, of course, is an afterthought, but our clinicians, they never give you the history correctly, and then they're always waiting to blame the pathologist for any wrong interpretation that is made on the slides, but never once will blame themselves for not providing the history. Pathology is supposed to be clinical pathological correlation, so you need to provide all this information to make the right diagnosis. So this is a case of metastatic colonic carcinoma. So the hints here were the history. The malignant nature of the cells is usually not difficult to see. There's tumor diathesis, but is less than you see with typical invasive carcinomas of the cervix. Signet ring formation are large sheets of tall carbonous cells, vacuolar cells parasiting at one edge usually suggests that this could be extracervical in origin and metastases. Now this is a 54-year-old lady who has history of postmenopausal bleeding. She had a history of fibroids and a large fiber mass protruding to the cervical os. You see these cells, dirty background, so you're already thinking in the realm of carcinoma. Then you have the cells which spindle, large oval nuclei, so you think, oh, could be squamous cell carcinoma, correct? Then you see that there are not much cigar-shaped nuclei, prominent 1 to 2 nucleoli. So it doesn't really typically look like the classic endocervical endometrial type of carcinoma I've told you. But there are spindle cells and there are oval nuclei, so you think, oh, and there's diathesis, so and the mass of the cervix, so this is squamous cell carcinoma. So it's just called malignant cells present. And this is the histology of the mass, and of course you know that these are malignant spindle cells with rampant mitoses. The cells have a lot of pink cytoplasm. This was a high-grade leiomyosarcoma of the uterus. So leiomyosarcoma in smears is rare. You can see scattered as well as loose aggregates of atypical cells, the bizarre, including spindle, epithelioid, and tadpole forms. There's diathesis in the backgrounds. In liquid preparations, you can have the nuclear membrane details very well preserved, and the cells tend to round up. Cigar-shaped nuclei are seen, which might point to a diagnosis. Chromatin less coarse than squamous discoliosis. And mature smears may be admixed because it's ulcerating sometimes. Sometimes this could be the smear changes may show features consistent with the triple MT like I showed you previously. This is a 91-year-old lady, postmenopausal nodule in vagina, and these are cells. So the cells you see are abnormal. There's no problem of diagnosing these malignant cells. But then you see that the cells have some brownish black pigments. So of course, this is a seminar in which I'm talking about glandular, and now I've gone into the area of extracervical. So you think, of course, there's so much pigment. Of course, this is melanoma. But did you make the diagnosis of melanoma without any history? So this, of course, is a melanoma because I know that this patient had a previous history of melanoma. And then the histology shows a very classic appearance of a melanoma. And then you see that the cells in the background, sometimes the melanoma cells may not have pigment, where the issue may be a problem to diagnose melanoma confidently. And here you see that in the second case, the cells do not have a lot of pigment. They are slightly dissociated, but there is, if you very carefully see, there's pigment here. Yeah. So this is a case of melanoma, very rare, usually ulcerated polypoidal nodule. Of course, you know, prognosis is quite poor. The cells are pleomorphic, they can be single or dissociated groups, prominent nucleoli. Melanin, as I said to you, may not be very obvious at times. There's diathesis. Sometimes the cells can be quite small and bland, so you have to be very careful not to miss them. And of course, you do ancillary tests, and sometimes a biopsy will tell you, or there's a concurrent biopsy which will make the diagnosis much easier. So what should be our approach to metastatic lesions? So history, very, very important. Metastasis of cervix is not common and usually occurs in the presence when the disease is advanced. The mucosa is quite intact, and the tumor tends to undermine the overlying epithelium. Sites from where the metastases occur: endometrium, vagina, vulva, ovary, fallopian tube, GI tract, breast. Sometimes you can have direct invasion of the bladder and from the rectum. And remember, as I said to you, the more you see and when you think about it, that the cytology does look a bit different from classic endocervical or endometrial carcinomas. If malignant small cells are seen in a patient with a known primary, always review the original tumor histology to compare. So now, in the context of kinase smears, how is HPV testing used? So you can either do reflex testing for low-grade smears, borderline smears. You can use HPV test as a test of cure following treatment, or now you can use HPV as primary HPV screening. So what is then the effect of primary HPV testing and vaccination on cervical cytology? So high-risk HPV compared to LBZ tends to detect 50% more CI in 2 hours and 40% CI in 3 hours and 30% more cervical cancers, thus enabling you to diagnose more cases and extend the screening interval to 5 years. How would this translate in the screening population? Screening with high-risk HPV translates to 20% decrease in overall incidence of cancer. Initially, there will be an increased demand for colposcopy following a high-risk HPV diagnosis and negative cytology. The effect will be temporary, and this will be aided with high clearance rates with the longer. So if you increase the interval longer, that helps the patient to clear the infection and low-grade lesions. So the study in the UK predicted that primary HPV testing would decrease annual cytology workload by a few million, would decrease the incidence of cervical cancer by so many hundred cases, and the cost, which is the most important bit in a screening program that is funded by the government, is the huge cost benefit. And also, how does vaccination play a role? And vaccination is shown in many studies to decrease the incidence of high-grade HCL lesions. Then I leave you with some of these papers which are related to the impact of HPV, primary HPV testing, and why it was planned to introduce this in the screening of patients in the NHS. But having discussed for the past 47 minutes and 43 seconds all about cervix and the lesions, squamous and glandular and metastatic, I leave you with this smear. Clusters of cells and vacuolation, overlapping, some inflammation. So what is this? Is this neoplastic? Is this negative? What do you all think? So at that point, the person who reported this smear called acus follow neoplasia for all the reasons that I've explained to you in this while describing this smear. And what is this? This squamous metaplasia. So after this whole lecture, are we any more learned and more confident in diagnosing? Who knows? I leave it to you all to make that decision. Okay, so there are a lot of new technologies in cervical cytology now. So we either can pretend that we don't want to adapt to new technology or would like to take them on board and use them with the knowledge that we already have of cervical cytology and adapt to these technologies and incorporate them into our routine practice. And to remember that cytology is not going away. A lot of people say, oh, AI, HPV testing will replace pathologists. Not in this lifetime. Of course, cytology will still play a role. It may not play the same role it played 20 years ago, perhaps. And we may not need as many cytologists. So cytologists will always be needed. So thank you very much for your attention. Whilst I'm not live, if you have any questions.
It's a thank you, Nigir. It's a pre-recorded audio. So I think 7-8 minutes are there. Somebody want to initiate a discussion on this? There is no problem. 7 minutes is there. Dr. Bharat.
Good evening, sir.
Yeah, 7 minutes are there.
Yes.
Somebody want to initiate a discussion?
I have been just putting some points. I couldn't resist. I think it was a very nice presentation, and I felt the last slide was like a cherry on top. I echo the sentiments, and Radhika ma'am is just there. I think it's so timely. Good evening, ma'am. And I think we do echo that cytology is there. Of course, HPV reflex testing, HPV testing has made a huge impact, and so has vaccination. The percentages in the second last slide that Dr. Mihir shared is very educated for all of us. And I think, so I just had some minor, things about how ASCUS is triage. Generally, we see with, and I think that Dr. Mihir also in his slide mentioned that they triage with reflex HPV and also LCIL. But sometimes in simultaneous colposcopy, if they find something abnormal, so they take a biopsy, and that's how we get to be knowing that ASCUS was perhaps a squamous metaplasia, or it turned out to be CIN1. Maybe Dr. Radhika can add towards, what her thoughts would be on this presentation. But I really enjoyed it, and thank you so much, sir.
I would really echo what Dr. Bharat said. It was an excellent presentation with such a wide spectrum of cases. I think he didn't leave a single thing untouched. Practically every lesion that one can see in the cervix with the corresponding cytology. And it's so hard to get cytology of some of the, for example, metastasis into the cervix. I mean, that's really, it was mind-blowing, I would say. And yes, there would be challenges in actually making a diagnosis of some of the rare entities in pap smears. But then, of course, we all know that the purpose of pap smear is not to make a diagnosis, but it's essentially a screening tool. And obviously, all of these would be followed by cervical biopsies. And then you would always go back, like Dr. Mee rightly pointed out, that you always go back and do a cytohisto correlation and try to see where your cells cellular morphology, how it would actually fit into the tissue diagnosis and the histomorphology. And it's a continuous process of learning and improving your own skills there, I think. And I think his last comment was really, it brought a lot of joy. He said, we cannot wish away cytology so soon. And I was just at the ISCCP monthly webinar just before I joined in. That's why I got a little late today. And of course, they are all committed to cervical pathology. And I had to speak there on pap smear interpretation, of course. So yes, our clinicians have still not given up pap smears at all, at least in our lifetime. For the next 20 years or so, at least India has still not even started HPV vaccination. So once you start HPV vaccination, that cohort of girls, when they become women, maybe in them the pap smear may not be so important and HPV testing becomes mandatory. But you know, that is still a very long way for us to go. We haven't even initiated HPV vaccination. So I think as a tool that is I think for a country with modest resources like ours, pap smear comes in between the VIA and the HPV testing. And wherever possible, of course, in the cities where affordable and feasible and where the facility is available, can go hand in hand as a co-test. And of course, he has brought out wonderfully the indications for HPV testing in the current scenario. Thank you so much, Dr. Meher. It was just one comment which Dr. Indu has already mentioned, is that when one sees endometrial cells in the pap smear, currently cutoff being used as per the Bethesda is 45 years rather than 40 years, but maybe locally in different countries, they could be having slightly different cutoffs. Otherwise, it was great listening to you and seeing the slides. Thank you. Over to you.
Thank you, madam. Thank you, Bharat. I think we can move on to the...
Yes, sir. Thank you. Thank you, ma'am and sir, for those words. So we'll move on to the next topic. I invite Dr. Indu Anaya to introduce our next speaker. Madam is currently working as a professor at Amrita Institute of Medical Science, Kochi. Her areas of interest are hematopoietic pathology and gynec pathology. Over to you, madam.
Thank you, Dr. Annie. The next speaker, I think, doesn't need much introduction to most of us, but seeing her highly inspirational CV, I think it's my proud privilege to introduce her. To mention a few of her achievements, she had the Commonwealth Scholarship Award, and she's the recipient of Ernest Fernandez Award. And as we know, she's a co-author in the latest WHO of FGT. And she has so many international publications and book chapters. And her extracurricular interests include travel, music, and above all, I should say that she radiates an infectious enthusiasm. And she's here to talk on borderline ovarian tumors, which is an ever perplexing topic. And I should say each time I encounter one, end up taking loads of fresh bits and again start reading and rereading WHO FGT. So over to you, ma'am.
Thank you, Indu, for your very kind words of introduction. And thanks to the organizers, again, Dr. Indu, for having invited me to this forum and for also having assigned me this topic of borderline ovarian tumors, which is a topic somewhat close to my heart. It is a challenging area in itself, as you can see. So I think without wasting time, we'll to the top. I know that, as a maybe senior resident, there was a lot of talk of it. This term had got introduced. And my professor in those days would say there are no borderline tumors, there are only borderline pathologists. That if you can't make up your mind, well, you would simply say borderline. But we know now that is not really true, and this is a definite entity, and we will see why it is a definite entity. And we know that there are neoplasms that are in between the frankly benign and the frankly malignant tumors. In other words, these are tumors with a much lower malignant potential than the usual carcinomas, and they pose challenges in diagnosis. And if you're not aware of the varied histomorphology, these tumors can easily be overdiagnosed as malignant tumors. Frequently, these tumors occur in young women, and therefore an accurate diagnosis is very essential for management. And over the next half an hour or so, I will try to cover the spectrum of the borderline ovarian tumors, including their morphology, gross and microscopic, highlight the nuances and the challenges in the diagnosis, and have a brief understanding of the molecular pathogenesis. And very importantly, as pathologists, I think we should also look into some of the clinical aspects and the management of these tumors. So so we know that the three main categories of epithelial tumors are serous, the mucinous, and the endometrioid. So each one of these has its borderline counterpart. And the less common ones are the seromucinous, the clear cell, and the Brenner, which has their borderline counterpart. In the serous, we shall be discussing on the micropapillary variant, which has its own space in the blue book. So this was the old terminology we used to use: atypically proliferative serous tumor, or APM, TAPST, and so on. Then it became borderline serous, mucinous, etc. tumors. Now they made it serous borderline tumor, mucinous borderline tumor. Which comes first? Does the borderline come first, or the type of tumor comes first, histotype? Earlier on, there was some terms like borderline tumors of low malignant potential. That has no meaning at all. And borderline serous carcinoma, again, you can't use borderline serous carcinoma as one of the terms. Obviously, that is out, and these two are also out of fashion. So currently, the term in the blue book again is you use whether it is serous or mucinous or whatever histotype it is, followed by the term borderline tumor. So this is again the WHO classification. So let's look at it. When we look at the frequency of borderline tumors, the bulk of it is serous, followed by the mucinous, rarely endometrioid, and all the other subtypes. And therefore, the major part of this talk is going to be devoted to the borderline serous tumors, and a little bit on the mucinous, and briefly touch upon the endometrioid and the other variants. So if you look at these serous tumors, we know on the benign end of the spectrum, you have the cystadenoma and the cystadenofibroma. And in the borderline, of course, we have the conventional one and the micropapillary variant. And in the malignant tumors, we have high-grade serous carcinoma versus low-grade serous carcinoma. Now, there was this term called low-grade non-invasive serous carcinoma, which was used interchangeably with the micropapillary variant. But now it has been shifted into the malignant category. So first, let us see, high-grade serous carcinoma, which is such a common diagnosis and these are the various patterns that you can have, this kind of a papillary kind of configuration, a solid pattern, cribriform, you have glandular, papillary cribriform areas and all that. And this is, for example, the tumor of high-grade serous carcinoma, which had a predominant papillary architecture. But look at the necrosis here. I just want to ask you, is my arrow visible to you when I'm using the arrow? If I'm using this arrow? Yes. Yeah, okay, that's great. And look at the papillae. These are all the non-hierarchical papillae. So let's see what it means. But basically, when we look at a high-grade serous carcinoma, we know that the nucleus is high-grade. So there's apoptosis, the mitosis, coarse nuclear chromatin. You look at the mitosis there, here, and some of the apoptotic nuclei, which are very common in a high-grade nuclear, high-grade serous carcinoma. Now, on the other hand, this is an example of a low-grade serous carcinoma, which can resemble a serous borderline tumor. However, here there is more nuclear ATP. And look at the papillae, they're all of the same size somewhat. There is no hierarchy, large and small, large to small to small. So again, this is called non-hierarchy. You generally don't see necrosis. You don't see too much ATPR. There could be some nuclear ATPR. You generally don't see mitosis. It could be an occasional mitotic figure. And some somatic calcification can be present. But what again tells you it is a carcinoma is the presence of invasion. So here again, when we compare low grade versus high grade, the nuclear grade is low in low grade serous carcinoma as compared to the high grade serous carcinomas. But what defines both, whether it is high grade or low grade, very important is that invasive carcinoma is defined by stromal invasion. And this is what you mean by stromal invasion. You have this haphazard pattern of glands invading the stroma, which has this kind of an altered kind of appearance. So this is easily identifiable at the low magnification when you can identify this as a clear-cut focus of invasion. So coming to the tropic proper, serous borderline tumors, these are non-invasive, they're low-grade, they're proliferative serous neoplasms. Essentially, they're tumors that display greater epithelial proliferation and ATPR than the benign serous tumors, but of course lesser than the low-grade serous carcinoma. So this is a typical gross photograph of a serous borderline tumor, which can be of any size, but generally they are more than 5 centimeters. About a third of them are bilateral. Predominantly, it's a cystic neoplasm. So you see, there can be a uniloculated or a multiloculated cyst. The outer surface may be smooth or show excrescences, but the inner lining here is showing it's studded with papillary excrescences. So it may not be studded all over the place. It could be focal. And these papillae can range from pinhead to, these kind of excrescences, which are varying over a few millimeters to even a few centimeters in diameter. So here is another case. For example, in the right side, you see this multicystic neoplasm, and you see these papillary excrescences. Whereas on the left, the ovary is completely, you don't know where the ovary is. It's completely the extensively surface involvement of the ovary is present. And of course, this case has also undergone a omentectomy. So what do we see under the microscope? You take multiple sections, of course, and what you see is this kind of hierarchical papillae, complex branching pattern. So it goes from large to small. So this is a large, then small and small. Finally, it terminates in detached tufts of epithelial cells. On the other hand, in a serous cystadenoma, it's just a single layer of bland serous epithelial cells. There's no complexity of architecture. There is no proliferation. There's no tufting. There's no hierarchy, nothing. So that is a serous cystadenoma. But the cutoff for proliferation is, there could be some cases where you are wondering, is it a borderline or a benign? And there the cutoff is around 10% of the surface area. So again, another picture to show you the hierarchical arrangement of the papillae, from a large one to a smaller one to a smaller one to a smaller one, and finally detached tufts of cells. So here is, for example, simply I'm showing you the old slide, the high-grade serous carcinoma on the left, and this is the serous borderline tumor. Okay, so there are definitely differences between the two, apart from the fact that in a high grade, the nuclear grade is obviously very much higher. Now, the types of serous epithelium, you can get this kind of a serous epithelium, which is showing you nice hobnailing cells with a lot of eosinophilic cytoplasm and nucleus pushed to the edge, the hobnailing. And then, of course, you have the ciliated columnar type, serous kind of tubal type of epithelium. So another aspect is the epithelial stratification, which is a feature of these borderline tumors, just at higher magnification to show you the degree of epithelial stratification. And again, the cellular ATPR, which can be mild to moderate, can have variable numbers of these kind of polygonal cells, hobnail cells with moderately enlarged hyperchromatic nuclei. Small nucleoli can also be seen. So now here, for example, very important is, how do you say that this is not a carcinoma and this is borderline tumor? So you have to look for evidence of stromal invasion. Now you evaluate the epithelial stromal interface here. For example, this is the capsule, and here you have all these papillary excrescences. You can evaluate the stroma here. Further on, within the stroma of the papillae also, you look at the epithelial stromal interface for evidence of any stromal invasion. Now, mind you, what these things that are there in the stroma are not stromal invasion. They are merely dips and the cuts that is giving you that impression. Now, look at this. Here is a case of a low-grade serous carcinoma, and this is typically invasion because there are these groups of cells and they are surrounded by this kind of a nice retraction artifact. On top of that, it's a very haphazard at low magnification. It will appear very haphazard infiltration. The stroma appears a little different from the rest of the stroma. So all these are telling you that these are stromal invasion. So what is this? Is this stromal invasion or not? Yes, this is stromal invasion, but this is not stromal invasion. This is not stromal invasion. So I go back, stromal invasion, and these are not stromal invasion. Okay, the basement membrane is still intact, and these are merely cuts and caused by the dipping of the surface epithelium and when you have a cut like that. Again, mere presence of pseudomatous calcification in the stroma does not itself constitute stromal invasion. Ovarian surface involvement is very important and has to be recorded. You see here, when you get a nice fresh specimen from the OT, just a minute. So this is full of these papillary excrescences. Now, tumors with an exophytic component are associated with implants in 50 to 70% of the cases, compared to, around 20%, 15 to 20%, I would say, in tumors that are completely intracystic, don't have a surface component. And just like we have a borderline serous, neoplasm, we can also the cystadenofibromatosis component also, which can be borderline. So let's spend some time on the serous borderline tumor of the micropapillary variant. So here you have these elongated micropapillae without the stromal course, and these are 5 times longer than wider. Now, this micropapillary architecture should be present in more than 10% of the tumor area to qualify for this diagnosis. Again, you have to make sure that there's no invasion. Generally, these micropapillary variant, it is a non-hierarchical branching, and the nuclear atypia is greater than what you would see in the usual type of borderline tumor. So this is what it is, the micropapillae, which are long, slender, 5 times taller than they are wider, and they have scant a scant stromal course, and they can give typically what is known as a medusa head appearance. So medusa is a Greek mythological figure, and she has these kind of locks coming out of her head. And just compare it, this is the face, and this is the streaming micropapillae, which gives you what is known as a medusa head appearance. Now, I have seen quite often, people get confused with the micropapillary variant in SBT that we're talking of, this ovarian tumor. In contrast, they compare it to the micropapillary urothelial carcinoma, where it's an entirely different scenario. And again, the micropapillary carcinoma in the breast is something that doesn't look like any of these. So this is the definition, and this is how SBT, the micropapillary variant, actually looks. So you also get these kind of cuboidal cells. You could see small cherry red nucleolus. The mitotic index is generally low in such, but it is higher than the usual type of SBT. So sometimes there can be fusion of these papillae, which form these kind of a slit-like spaces, giving you this cribriform kind of appearance. Focally, so you can also see these kind of pseudomatous calcification, and this is just to show you the morphology at higher magnification of the nuclei of the micropapillary variant. So what are the implications for SBT with micropapillary features? Now, these are more aggressive tumors and should be considered, this was the older, again, terminology that people thought it should be considered as a low-grade serous carcinoma because they tend to have peritoneal implants, but then others disagreed. So this is one of my old slides I put in, but what is important right now is to call it as an SBT micropapillary variant, thorough sampling of all papillary tumors to make sure that there is no focus of an invasive carcinoma. Because the survival rates are not very, very different, although they are more aggressive and they can have more implants. So as compared to the SBT NOS, which presents as advanced stage disease in 13% of the cases, the micropapillary type presents this in twice more frequently that is, they're present with advanced stage disease in 27% of the cases. It has a slightly more aggressive behavior than the usual type. Then we move on to serous borderline tumors with micro-invasion. So what do we mean by micro-invasion? This is a term that has been applied to these clusters of cells in the stroma with abundant eosinophilic cytoplasm measuring less than 5 mm in the greatest dimension. They're individual cells or small clusters of cells, and they have typically this kind of a retraction artifact. But people think that these are likely, to be terminally differentiated or senescent cells, and they really do not have any adverse impact on survival. Again, remember that this is a lesion that is quite rare, but requires a rigorous sampling. And this is not one of my slides. I have seen a couple of cases with micro-invasion. Somehow I could not get those slides for photography, and last minute I just used this from the net. But generally, this is what you see. You see their clear retraction artifact. You see small clusters of cells with a eosinophilic cytoplasm. And this is, again, a very uncommon thing. And rarely, this is from, again, one of our cases, who was a pregnant lady, and she had these serous borderline tumors. We saw these areas like this, and we were quite worried. But then we looked into literature, and so this is actually an infarction of the papilla. It can happen sometimes, and although unusual, it is something that you don't worry and fret about. It just mentioned that focally there is this kind of the papilla showing infarction, and that is it. It doesn't make any difference to the prognosis or the behavior or the management. And we had one case wherein there was an SBT in the ovary, typical serous borderline tumor, but they had done a pelvic lymph node sampling in this case because they appeared to be suspicious to the surgeon. And indeed, it did show involvement into the lymph nodes. There was the extension of this kind of a tumor, which of course you have to distinguish it from pelvic endosalpingiosis and other things before you say that there is lymph nodal involvement. Immunohistochemistry not really required, but just to complete the picture, they are positive for WT1, which is a marker for serous tumors. Obviously, P53 will be of the wild type. They can show patchy ER and patchy PR positivity. Let's move on to the implants, which is a very important concept to have. So now previously, these implants were divided as non-invasive and invasive implants. However, the realization that invasive implants behave similar to the low-grade serous carcinomas. Now, basically, right now, when we call it an invasive implant, there's no such thing as an invasive implant. By default, when you use the term implant, it is a non-invasive implant. If it is an invasive implant, it will go automatically as a low-grade serous carcinoma. So this is what you have to take. When you use the term implant, essentially it is a non-invasive implant. So this is one of our cases where in about 13% of the cases of SBT, peritoneal implants are noted. And obviously, like I told you that this frequency of these implants is higher where you have the surface involvement. So there are two types. That is, the one is the epithelial and second is the desmoplastic implant. Essentially, this is an epithelial implant which resembles the primary SBT tumor. So you can have papillae like this, you can have submamatous bodies, and it's kind of otherwise bland and sitting there. So this is a nice picture of an epithelial implant. Another picture from another focus to show you the typical epithelial implant there. Now, here was another case wherein it had a focal micropapillary architecture, was seen in less than 10%. Otherwise, it was conventional SBT, but there were also ovarian surface involvement was there, and there were peritoneal implants. Now, in some of the epithelial implants, you can see this extensive surface granulation tissue kind of response. And these, the lining cells, they resemble, sometimes you're wondering, are they epithelial or mesothelial? They can have a moderate eosinophilic cytoplasm. There can be a lot of inflammation and, this kind of, it gives the typical granulation tissue kind of an appearance. And here is another case, which is again a non-invasive implant, but it is showing you significant desmoplasia. But look at the glands that are there, which are kind of slit-like, but they have a very orderly appearance. So this is very important. So please evaluate such sections at the low magnification. It's only at the low magnification that you see they're kind of orderly. So, you know, all of them, if you look at this surface, they have a kind of a parallel, typical orientation. There's no haphazard orientation, although there is desmoplasia. So, so this is an example of a desmoplastic implant that can be seen in cases of serous borderline tumor. This is at higher magnification to show you a desmoplastic implant. Again, you could have on the surface, you could have some sort of a granulation tissue, you could have fibrinopurulent exudative reaction, etc., which are associated around the implants. So here was a tumor, for example, in a 26-year-old female. Now, unfortunately, this is an online audience. I want you to tell me what would you rate this? What would you call this? Was it what we saw? Are you going to call this a desmoplastic, non-invasive implant? Or are you going to call this an invasive implant and, I mean, put it into the category of low-grade serous carcinoma? You may put your things in the chat box and the moderator can tell me. Otherwise, typically the ovarian tumor was borderline tumor, serous borderline tumor, but this is what we saw in the momentum. Any responses?
Nothing so far, ma'am.
I think there will be a lag before they kind of respond, I guess. But your own thoughts?
Ma'am, it's non-invasive.
I think it's unfair to ask anyone on the basis of an image, but I think there was facade, there was desmoplasia, altered stromal response. And this is just to show you an invasive implant. And of course, in the current terminology, go off as a low-grade serous carcinoma. So this is what you need to understand. Second, we move on to an area which is again would come frequently in your practice is peritoneal washings. And as part of staging surgery, peritoneal washings are routinely performed in all cases when they operate these cases. And a proportion of them, this is what we saw in one of the cases. We saw plenty of these ball-like aggregates. This is a pap-stained LBC smear, and this is the corresponding Ginza smear. So this was actually what happened is the cytology gets submitted, the very next day, but the histology takes about, the sections take about 3 to 4 days to come, 3 days to come. So this was signed out by the reporting pathologist as positive for carcinoma. And but when the rest of the sections came, it was just a serous borderline tumor. There were a lot of surface papillary excrescences. We went and looked back at the slides, and then we everything could fit into that there was no carcinoma as such. It was a borderline tumor, but there was involvement of the peritoneum. There was shedding of these cells into the peritoneum. That's why the peritoneal washings were positive, because there was extensive surface involvement. So I think the lesson we have learned, and we have actually published also on it, is do not report them as positive for malignancy. Report it as positive for neoplasm. And one clue is that the nuclear grade is not high. So these kind of ball-like papillary clusters could either have come from an SBT with surface involvement, or could have come from a low-grade serous carcinoma. They're not from a high-grade serous carcinoma. You can even hold the report, go check on the histopathology, and then send a final report to the clinician. So and one more such case where there was ovarian surface involvement was there. She didn't even have implants, but the peritoneal washings were positive for the tumor cells. So it was positive for neoplastic cells. So overall, implants can be seen in various series in 20 to 46% of the cases. More common in cases with an exophytic ovarian surface component. And for the surgeons, yes, whenever we have when they suspect a borderline ovarian tumor, they have to sample extensively the cul-de-sac, the pelvic peritoneum, the peritoneal surfaces, and also omentum, and everything has to be sampled. So you will get a lot of peritoneal biopsies. You will get omentectomy also. The pathologist also should liberally sample the submitted specimen so that we are able to type what the implants are appropriately. So another case I just want to share with you is that serous borderline tumors tend to be bilateral in 30% of the cases approximately, but many of these patients are young. So this was a young patient, and the surgeon did one side adnexectomy, salpingo-oophorectomy, but on the other side, they said, well, it looks okay, slightly enlarged ovary. We are going to just take a biopsy. So when they took a biopsy, this is what we saw in the biopsy. And we told them that, you can see the normal residual ovarian follicles also there. And this was a microscopic focus of the tumor. So we told them that there is a focus in the contralateral ovary. A good chunk of the ovary had been left behind, but she was followed up, and the ovary started enlarging. And within a few months, they had to remove the contralateral ovary as well. So another aspect we have faced sometimes is the patient is pregnant, and on imaging findings, they think it's a borderline tumor. Of course, sometimes they would go and do an adnexectomy in the second trimester. Remember that pregnancy can have some effect, that the lining cells can be more abundant and have more eosinophilic cytoplasm. And there are some series which have said that there is a higher frequency of stromal micro-invasion if the patient has a borderline tumor during pregnancy. And also remember that you can have purely peritoneal presentations of serous borderline tumors. This was a case which was classified as a peritoneal SBT because the ovaries were normal and there was involvement of the pelvic peritoneum. So with this, we will move on to the mucinous tumors. I think it's only when pathologists actually, you can read this saying patterns. You have to look for patterns in a slide, and that can shed a lot of light on pathogenesis and also management of the disease. So we move on to mucinous borderline tumors, and this is actually...
Madam, can I intervene for a minute?
Please, yes.
Yeah, for the last, your question, I actually read out the first response is non-invasive. I think many of them have answered as invasive.
Yeah, that's very nice, very nice. So I think even from one image, I have been able to convey the right diagnosis. Good for the audience. Congratulations on all of you who told me the correct diagnosis.
Okay, madam.
Yeah, so this is really one more thing. Well, I can tell you this is not in Kerala, this is in Northeast. Another beautiful place that people should visit. This is the Living Roots Bridge, across this. It is in Cherrapunji. So we move on to mucinous borderline tumors. Again, these are again non-invasive. They are mucinous neoplasms and with gastrointestinal type differentiation. So, earlier, maybe a few years back, we were dividing them as those with endocervical type of epithelium and those with intestinal type of epithelium. So that is out. These are now in the new, the blue book. It simply says, just reproduced it, that these are mucinous neoplasms with gastrointestinal type differentiation. So again, there is a wide age range, including pediatric patients. They are the second most common following the serous tumors. But in some countries, they are more frequent than serous tumors. And of course, they're associated, of course, with the KRAS mutations in a large majority. So again, in mucinous, you could again have benign, borderline, malignant counterparts, just to show you a case of mucinous carcinoma. Okay, here you have very complex architecture, you have necrosis, and at high magnification, you have significant nucleotopia. You sometimes start seeing mitosis, fragmented glands, and so on. No problem. All of us are going to call this mucinous carcinoma. This is from another case. Sometimes there can be mucodepletion focally also. So again, this is again another picture there. Here is a case of a mucinous cystadenoma, which had, this kind of epithelium. So earlier I used to call this as an endocervical type epithelium. This I would call this on this side as an intestinal type of epithelium with goblet cells and all that. But simply called nowadays as mucinous neoplasms. They can have gastrointestinal type of, so the gastric and the intestinal type. You could have focal areas of proliferation. So again, there is a cutoff. So here was a tumor. We were wondering, should I call it benign or should we call it borderline? So you would again take your judgment call. Is it 10% or more? Then you put it into borderline. If less, you call it just benign. So the gross features here in mucinous tumors are very large, generally the large tumors, 20 centimeters, even more. Sometimes they come into you in a bucket. Mucinous borderline tumors are almost always unilateral. They have the smooth external surface, multiloculated cystic appearance with mucinous material. But you could have variable amounts of solid components. Such large tumors, you have to cut them, bread loaf them meticulously and look for the presence of any solid areas, any area which looks different. So this is what it is, the surface lining epithelium, like I already showed you. You can have stratification. There will be, this kind of crypt-like, and you can have villiform kind of papillary luminal projections. And the degree of ATPR is again low grade. You could also have goblet cells there and also Paneth cells in the lining epithelium, just like you have the gastrointestinal type of epithelium. Now, mucinous tumors, why should they be sampled even more thoroughly? Now, the reason is that an important point here is the heterogeneity of mucinous tumors. So you could have a mucinous borderline tumor, which can have an area that is simply looking very bland and benign. And on the other hand, there could be occult areas of non-invasive carcinoma. There could even be a small focus of invasive carcinoma. So this is why you have to make a thorough sampling of mucinous tumors. So the recommendation here is one block. If a tumor is less than 10 centimeters, it is one block for every centimeter of the tumor. But if a tumor is more than 10 centimeters, it is 2 sections per centimeter of the tumor. So a larger tumor must be sampled even more thoroughly in the case of mucinous tumors. And very important is use common sense. You have to sample every different looking area. So you have this complexity which you have to appreciate at low magnification. You have large cystic spaces. You can have glands of varying sizes. You have these, smaller daughter cysts, having complexity, but more of an orderly pattern in the mucinous borderline tumors. And again, this we have already highlighted the lining, the tufting, the stratification, and so on and so forth. And just to compare the nuclear ATPR, this is kind of more morphologically benign appearing. Here you can see a greater degree of nuclear ATPR, greater degree of stratification in a borderline tumor. Sometimes you can see pools of mucin in the ovarian stroma, which you refer to as pseudomyxoma ovaria. It can elicit an inflammatory response, but none of these would constitute invasion. You can also have force of non-invasive carcinoma or intraepithelial carcinoma. This is again not from my picture, from the again. So this is again slightly uncommon, where suddenly you would see that there is a focus, have high nuclear grade, crowding, multilayering. You have these bridging, cribriforming, etc. So it's obviously this is looking a very bad area. So you would call this an intraepithelial carcinoma. Make sure that there is no invasion. But if this ATPR is very diffuse or very marked, then you would consider the diagnosis of a mucinous carcinoma. Again, stromal micro-invasion is seen in about 9% of the cases. Here again, the criteria of 5 mm is given. So you have isolated cell clusters surrounded by the clear space, which is fibrous edematous with variable numbers of inflammatory cells. So multifocal, if you see multifocal stromal invasion, then you think of it as a frank mucinous carcinoma. But if it is very restricted, then only you would call it as a stromal micro-invasion in a case of mucinous borderline tumor. And last, very important, is the presence of mural nodules in mucinous borderline tumors. There are 3 types. One is the reactive sarcoma-like. Then you have anaplastic carcinoma and the pure sarcoma one. In the reactive sarcoma-like, there is variable mixture of spindle to round mononucleated cells with epulis-like giant cells with admixed inflammation. And these, of course, the other ones are the truly malignant transformation has occurred. So this was from one of our cases. This was a very large tumor measuring nearly 38 centimeters by 18 centimeters. Look at the cut surface, multiloculated cyst filled with mucinous material. And this was one of the cut surfaces. It was appearing, a little bit different here. So, of course, multiple sections have been taken. Nearly, we had some 40 sections from this tumor. And this is this is the mucinous epithelium there. And then here was the solid area, which is showing like this. So majority of the sections were showing something like that, similar to a mucinous borderline tumor, like this, no problem. There was no invasion. There was no carcinoma there. But the solid areas here, which would maybe considered as a mural nodule, showing features of a sarcoma. We, of course, went on and did a lot of IHC on this, Vimentin, Desmin, etc., etc., etc. and all markers were negative. So this was labeled as an undifferentiated sarcoma presenting in the context of an MBT with a mural nodule. Of course, the prognosis is excellent for stage 1 with an overall survival of 95 to 100%. And only if there's micro-invasion, there can be a higher recurrence rate. Then we move on to borderline tumors of mixed epithelial type, the seromucinous types, which have a strong association with endometriosis. It is a combination of this kind of a papillary architecture with cells which are showing mucin. So the lining cells can show an admixture of ciliated, hobnail, endometrioid, mucinous, and eosinophilic cells. And of course, they're closely associated with endometriosis, and that's why you have this ARID1A expression loss, etc., in these kind of borderline seromucinous tumors. And just to complete the picture, here is a borderline endometrioid tumor. I've seen a couple of cases, but this is taken from a publication where, again, if you ask me, sometimes the difference is difficult. Is it borderline endometrioid, or is it simply a grade 1 endometrioid carcinoma? You could take the analogy of whether you're looking at complex atypical hyperplasia or whether you're looking at a well-differentiated adenocarcinoma in the endometrium. And that's exactly the situation that you're facing when you're looking at a borderline endometrioid tumor in the ovary versus an endometrioid carcinoma. Look at stromal invasion. There should be no confluent growth pattern, no destructive stromal invasion, and the proliferating glands, if they resemble atypical hyperplasia, that's when you go and call it as a borderline endometrioid tumor, which I would say quite a rare diagnosis. Let's look at frozen section for borderline ovarian tumors. Is it a good idea? Bad idea. Now, the dilemma often arises in young women with an ovarian mass. If it's benign, only cystectomy. If it's carcinoma, well, the whole works are done, THBSO, staging, etc., etc. But if it's borderline, it is usually a unilateral salpingo-oophorectomy, peritoneal exploration for implants, and plus minus a pelvic lymphadenectomy, plus minus a mammectomy. Now, mucinous tumors would pose a greater challenge than serous tumors. Now, thorough sampling is not possible when there's an intraoperative consultation and a frozen section. Maximum you can study 3-4 sections, not more. This is one old publication which has looked at frozen sections of borderline tumors, and they have cautioned that it has a low sensitivity. Overdiagnosis occurred in 6.6%, underdiagnosis in about 30%. In other words, when you get the permanent sections, what you have called as borderline and frozen becomes upgraded to an invasive carcinoma on permanent sections in nearly 1/3 of the cases. And that happens more often in mucinous tumors. So here is another meta-analysis which has looked at frozen sections of borderline tumors. And they looked at two kinds of pathological sign-outs. One was where the pathologist said it was simply borderline. And when the pathologist said at least borderline, by that they meant that they cannot exclude a invasive malignancy that was communicated to the clinician. And when they looked at the follow-up, when they looked at the permanent paraffin sections, when the pathologist called it simply borderline, the paraffin diagnosis of carcinoma was encountered in only about 9.7% of the cases, vis-a-vis 41% when it was signed out as at least borderline, but an invasive carcinoma could not be excluded. So I think you have to explain and educate the surgeon that there are limitations. It can be upgraded to invasive carcinoma on a permanent section. And as the entire tumor would have been sent to your, for frozen, go and have a look yourself. Look at the gross specimen. The gross specimen of a borderline tumor, if you've seen a few, you know that serous, it is easy. It will have lots of papillary excrescences. Mucinous, again, will have a more solid appearance, the borderline ones as compared to the benign counterparts. Select the worst looking areas for frozen, solid areas, larger papillary excrescences. Go and look at it yourself. You will be better when you're interpreting the microscopy. And again, you can tell them it's definitely borderline. There's no invasion in the section studied. However, of course, put in always this line, final diagnosis on permanent sections. Or you could say it's at least borderline, but you can't exclude malignancy. It's likely or whatever. But communicate to the clinician that the final diagnosis will be on permanent sections and that they should go and do a thorough exploration if they want to. Then, of course, we know that ultrasound imaging is very, very important. Transvaginal ultrasonography is important as a, preoperative imaging is always done. A CA 125 is always done, but the sensitivity for diagnosis of borderline is very low, only for at the range of 62%. And regarding the management, complete surgery for women who do not wish for the pregnancies, which will include peritoneal washings, total hysterectomy, THBSO, omentectomy, and multiple peritoneal biopsies. But in younger women who wish to preserve fertility, there is a role of conservative surgery. They could do any of these treatments, but surgery is all that is there for borderline ovarian tumors, because chemotherapy is of no value, not indicated. And successful pregnancies are documented in women who have undergone conservative surgery. Only a very small proportion go on to develop carcinomas, and when they do, it's usually of low grade. Then, of course, the survival is good. It's stage dependent. Of course, in 1, 2, 3, it's excellent 5-year survival. But look at the survival even in stage 4. If you look, it is a good survival as compared to high grade serous carcinomas, where the survival is dismal. So this is what you need to remember. How do they follow up after surgery? Generally, they do a transvaginal ultrasound, which detects local recurrence. So these patients generally tend to have a local recurrence in about 15 to 20% of the cases. And then there are reasons in serous tumors, in tumors where they have done a cystectomy, in tumors with surface involvement. These are the cases, and in tumors which have implants, these are the cases which tend to have a local recurrence, and usually that is a pelvic recurrence. I'm stressing a lot on the clinical management, because I think we pathologists, we're so much into our slides and images that we forget what is happening to the patient, and that is so important. Molecular aspects, I know all the younger people in the audience are wondering, why is this madam not talking about all these genetic mutations? Well, I have just put it in a nutshell here. Borderline serous tumors, BRAF and KRAS, both mutations. Mucinous tumors, KRAS. Endometrioid tumors, borderline endometrioid, it is beta-catenin, ARID1A, and PTEN. And of course, these go on to develop low-grade serous carcinoma, mucinous to mucinous carcinoma, endometrioid to endometrioid carcinomas. And in contrast, in the high-grade serous carcinomas, you have the TP53 and the BRCA1 or 2. So this is, in a broad nutshell, the mutational aspects of borderline tumors. So here we have the borderline mucinous and endometrioid, which give rise to the respective tumors that I've shown, which have a poor response to chemotherapy, which have to be managed by surgery. But if it's a high-grade serous carcinoma, in contrast, it responds to chemotherapy. So with this, I'll stop here and wish you all a very happy Independence Day. We had to fix this flag today on our rooftop on this Har Ghar Tiranga. Thank you all for a very patient hearing, and I'll be happy to take questions. Over to you.
Thank you so much, madam. So I think after this talk, we will be less borderline. There will be less number of borderline pathologists as far as diagnosis of borderline ovarian tumors are concerned. We have a few questions. One is that, madam, if the morphology is of a low-grade serous, but IHC is showing a P53 mutant type staining, then can we call it as a high-grade serous carcinoma?
Now, this is not outside the borderline domain. You are asking me morphology is low-grade serous carcinoma. Number one, when the P53 is a mutant type staining, and should you call it low-grade or high-grade? I mean, this can happen very, very rarely. So I think I would give a lot of importance to morphology. How sure you are that you are dealing with the nuclear morphology is so important. There are rare cases wherein a low-grade serous carcinoma has actually progressed to a high-grade serous carcinoma, or majority of the sections are showing low-grade, and then you have a couple of sections only which are showing a high-grade morphology. Those are extremely rare cases. So maybe it is, I think I would caution, I would again mention this to the clinician that this is what it is, that the nuclear morphology appears to be low-grade, but the P53 is of the mutant type. You could discuss such cases in your multi-tumor board, and then take a decision, take a call. And let me tell you that as far as the treatment is concerned, perhaps they would go on and give chemotherapy, whether you call it low grade or high grade, patient would still be put on the same kind of chemotherapy, which is platinum plus Taxol, would perhaps be given to the patient depending on the stage.
Okay, madam. Madam, another question
You
is
can,
how to...
I don't know how Bharat and Kedar are there. They can tell me this. I have maybe found this once. We had this rare case where we kept telling it's low grade. And then because even we had done a nice thorough CFIM of the fallopian tube as well, we did not find any lesion there. P53 was sitting on the fence. It was because the expression was seen in about 60% of the nuclei. So then, but we stuck to our low grade diagnosis. Then it was sent outside to some center in the US, and it was sent to some other center in India, which they said high grade because of this. Then it went to some other center in the US, they said it's low grade. So this confusion went on and on, low grade versus high grade. But then the patient was treated with platinum Taxol and she's doing well.
Madam, I'll give importance to the morphology. If it is clearly low-grade serous carcinoma, I'll go for low-grade serous carcinoma, not only based on P53 mutation. I think Dr. Soslo has described, 1 to 2% of such cases it can occur.
Yeah.
But I think the importance in my mind would be for the morphology.
So I will just add here, I incidentally had this case yesterday or day before signed up, and I was kind of stuck, and I'm so, happy to know that there's a query. I think it does happen, it's rare. So it's a P53 signature, diffuse positivity. I did a MIB1 that was 3 to 4%, and ER was diffusely positive, morphology was low grade. So I worded it out as, towards a low grade, commenting that these tumors can be heterogeneous, and we need to be aware that, this could be a forerunner towards this going to high grade. But at this point in time, I couldn't call it high grade because morphology was not fitting. But we've seen actually cases also of low grade going into high grade at other sites. So that does happen because they can acquire these mutations in transit or maybe later on. Having said that, a P53 signature can be seen even in a fallopian tube. So I think that's not enough to call it stick unless we see morphology that matches towards high grade. I think it's a combo of your, but I think we all agree towards morphology as the most important aspect.
Morphology is very important, and thorough sampling of fallopian tube actually helps. If you can actually demonstrate a stick in the fallopian tubes, it's telling you that the precursor lesion is there. I mean, stick has a definition which combines morphology along with P53 and Ki67 index. It should be 10%.
Absolutely.
Yeah. But I can tell you one more thing about serous versus endometrioid. Some of the borderline serous tumors, they have a somewhat less of a papillary and little more of a adenofibromatous, where you have the glands which mimic the endometrioid kind of glands. And we've had sometimes a lot of discussion, is this borderline endometrioid, borderline serous? And then you do a WT1 and you think, well, WT1 positive is serous and WT1 negative in endometrioid. But there is a recent publication, I can't recollect the exact author, but in the International Journal of Clinical Pathology, that some of the endometrioid tumors can show WT1 positivity. Absolutely. So a better IHC there, if you're very particular, is to do a PR. Because endometrioid tumors are generally PR positive. Don't depend on an ER, because ER can come both in serous and in endometrioid. So a PR would help you there. Having said that, again, whether you call it this or that, it's on the management. Always, I think I will ask the clinician and myself, kya farak padega? Please ask yourself this, because at the end of the day, what matters is the patient. So if whether you call it serous or endometrioid, it's only going to be a unilateral salpingo-oophorectomy at the end of the day. You don't have to worry your head too much about it. Having said that, yes, we have to be accurate in our diagnosis, but also these IHCs can sometimes be tricky unless you're aware of the fact that they are not always true to they're not very faithful all the time.
So there's one very nice comment actually Dr. McCluggage has made, who's done this phenomenal work, and Dr. Kedar knows him. So, any IHC can come, in any way in gynec pathology. So we need to be aware that we always, take it with morphology. And I truly agree. That was, I think, Dr. Cluggage's article only with mentions about WT1 and endometrioid also, as much as we've been utilizing to, reinforce a serous morphology. But I think what is important is the grade, and I won't take too much time because Dr. Kedar's talk is just lined up. So I think grade is important apart from, typing. So thank you.
Thank you, Dr. Bharat. Madam, can we take 2 more questions? Dr. Kedar, if you allow.
Yeah, of course, no problem. Please go ahead.
Yeah. Madam, one question is how to distinguish between artifactual and true stromal invasion.
I think I spent a lot of time on that. So look at it in low magnification, haphazard versus more orderly. Retraction artifact should be there in stromal invasion. In serous tumors, you don't find a retraction artifact, and an altered stroma. So the best evaluation is at low magnification. I showed you what is true, what is invasion, and what is not invasion.
Madam, and one more thing, for a mucinous carcinoma diagnosis, you go more by cytological features than by architectural. Is it so?
No, between benign and borderline, you have to have a complexity of architecture. And between borderline and malignant, yes, cytology can.
Yes, madam.
That is important. If it's a very bad, all over the place, your mitosis, apoptosis, and luminal necrosis, then you don't want to call that borderline. You call it a mucinous carcinoma. But having said that, please remember that mucinous, there's so much of heterogeneity that one part of the tumor can look borderline and another part, few more sections. So you have to have more thorough sampling for mucinous tumors, where you can have invasive carcinomas in one area, completely borderline in another area. You have to be careful in such cases.
Madam, one last question about the management. Between ovarian borderline with micro-invasion and a borderline micro-invasive carcinoma in a borderline, what is usually done? Because micro-invasion anyway will be kept on a follow-up, but what about micro-invasive carcinoma on follow-up only?
I don't know what you mean by micro-invasive carcinoma. Are you meaning a low-grade serous carcinoma? By that mean stroma? If it's a
Madam, in mucinous.
Right. I mean, if anything with micro-invasion has prognosis same as something without micro-invasion. So it's something if you recognize it, it is a red flag for you to actually go and sample the tumor more thoroughly and see that there's no focus of an actual invasive carcinoma somewhere. But if you have convinced yourself that you've done a good job and it's only one focus of micro-invasion, it's not going to matter to the patient at all. Management will remain the same. Okay. Prognosis will remain the same.
Thank you. Thank you so much, madam.
Thank you so much, Dr. Indu and all. And to Preeti.
Can I ask one question? Madam?
Yeah, Dr. Sadi.
Madam, Sadi, madam.
Madam, what is your experience with the low-grade borderline mucinous tumor and mucinous tumor of appendix?
What is the experience with? I didn't hear the full question. What is
madam, your experience on borderline mucinous tumor and low-grade mucinous tumor of appendix?
Right. Thank you for bringing that up. In fact, in all my previous talks of borderline mucinous tumors, I always had this section of the pseudomyxoma peritonei of the appendix.
Yeah.
But if you look at the current WHO, that part is removed. Okay. So that is a separate entity under diseases of the peritoneum, where you have pseudomyxoma peritonei, where you have, that is also now graded into grade 1, grade 2, grade 3. And we all know that pseudomyxoma peritonei is associated with appendicular tumors, mucinous neoplasms of the appendix, which incidentally can have ovarian involvement. And maybe, even 10 years ago, or even a few years ago, we were all calling them as borderline mucinous tumors of the ovary with pseudomyxoma peritonei, with lamen, low-grade mucinous neoplasms of the appendix. So, but now, since that was removed from the WHO book, so it is just an ovarian involvement. We should not give the label as borderline mucinous tumors of the ovary in such cases. It is mucinous neoplasm secondary to pseudomyxoma peritoneum is secondary to a low-grade mucinous neoplasm of the appendix. So if that has gone off into disease of the peritoneum, is secondary ovarian involvement, that is why I did not particularly put it here. In fact, I have slides here, but there's no time to show it. But we do have such cases. So in fact, clinicians, sometimes what happens is they are not detected the appendicular neoplasm, which is kind of hidden in the abdomen, and the ovarian neoplasms are larger and therefore detected. It comes to the gynecologist, but when they suspect on ultrasonography a mucinous neoplasm, invariably they go and look at the appendix at the time of surgery, and then the general surgeon is called upon, and then everything is dissected in toto. But there you have to report it as appendicular mucinous neoplasm, and then of course grade it and go on about it.
Okay, thank you, madam.
Thank you, madam.
Thank you, madam, and thank you, Radhika ma'am. So we move on to the next case, next talk. Sorry. To introduce the next speaker, I invite Dr. Preeti TR, Additional Professor, Regional Cancer Center, Thiruvananthapuram. Madam's areas of interest is gynecopathology. So over to you, madam.
Thank you, Annie. Now, from borderline tumors, we are moving on to ovarian carcinoma. And ovarian carcinomas are the commonest malignant ovarian tumors that we see. And many times, diagnosis of these tumors can be challenging. Sometimes the patient can present with advanced disease with ascites, and you will have to give a diagnosis on effusion cytology. Sometimes you can get a difficult to diagnose true-cut biopsy from an omental secondary or an adnexal cell mass. You can see them on frozen sections during the time of surgery. And then both on frozen sections and on permanent sections from excised specimens, sometimes it will be difficult to differentiate a primary from a metastasis and from a sex-coat stromal tumor. And sometimes subtyping of these tumors can be difficult. Today, we have Dr. Kedar Diodar, Professor of Pathology, Tata Memorial Hospital, Mumbai, to speak to us on ovarian carcinomas. To just introduce him formally, he did his MBBS and MD pathology from the Mumbai University, and he is a fellow of the Royal College of Pathologists. His interests, as we all know, the first one is gynec pathology. He's also interested in GI pathology and pathology audits. And he's in charge of the division of cytology and equasin cytology. Is the convener of gynecology oncology disease management group in Tata Memorial Hospital, NABH assessor for histo and cytopathology, and has more than 100 publications and has written chapters in many books. Now, over to you, Dr. Kedar.
Thank you, Dr. Preeti. Dr. Indu, can you hear me well?
Yes, Dr. Kedar.
Yeah, that's
Go
okay.
on,
Thank
please.
you. Thank you. First of all, I must thank Dr. Indu and Dr. Rajan regarding for their kind invitation. And it was indeed a real pleasure to listen to Dr. Radhika, madam. She's her usual exuding enthusiasm, madam. Thank you so much for your talk, because you have covered the borderline tumor so well that I'll be picking up threads from the talk and going on to the next talk as ovarian carcinomas. Let me just share the screen, please. Right. Okay. Can we? Is the screen visible okay now?
Yes,
Dr.
sir.
Preeti? Yeah. Thank you. Let's start. The talk today is on ovarian carcinomas, and we just had an extensive talk on the borderline ovarian tumors. So, briefly, the types of ovarian neoplasias are as we know, broad definitions are epithelial, which includes adenoma, borderline tumors, and carcinomas. Then we have other groups of sex-coat stromal tumors and germ cell tumors. These by far the most common subtypes. Then we have mixed sex-coat and germ cell tumors, mesenchymal tumors, mesothelial and miscellaneous tumors, tumor-like lesions, and not to forget metastatic disease to the ovary. Interestingly, if we see the evolution of our understanding of ovarian carcinomas, as I remember, the the oldest, at least in our knowledge, the old classification of primary ovarian surface malignancies that came in 1973 WHO classification, and it gave us several subtypes. The commonest being the serous adenocarcinoma. The next common was mucinous adenocarcinoma, and then the endometrioid, clear cell, transitional cells, squamous carcinomas, and undifferentiated and the mixed carcinomas followed. After that, by 2004, a new WHO classification came in, and during that time, we realized that the many mucinous adenocarcinomas of the ovary are indeed actually metastasis to the ovary from variety of organs. Madam Preeti just mentioned that it could be appendix, it could be and it could be gallbladder, it could be pancreas. So the mucinous adenocarcinoma percentage in the overall context went down, and the serous carcinoma became the commonest. And the next common became endometrioid and clear cell type. Mucinous adenocarcinoma took the back seat, or the fourth number. Mind you, the transitional cell carcinomas were still identified as a separate subtype of ovarian carcinomas in 2004 WHO classification. Then came the 2014 WHO classification, and by that time, between 2004 and 2014, we realized that what we call, or what we have been identifying as transitional cell carcinomas, they are all as areas which look like serous carcinomas. They all are WT1 positive. They all show P53 mutation type staining. And if you really sample extensively the serous carcinomas, we realize that the transitional carcinomas are nothing but a part of serous cell carcinomas. In fact, some people would argue that the set pattern, which is described in BRCA1 and BRCA2 mutation serous tumors, are indeed transitional cell carcinoma looking like areas. So 2014 classification, transitional cell carcinoma category went out, and it was indeed realized as a part of spectrum of serous carcinomas. And then we have introduced a separate category at that time, seromucinous tumors, in 2014 classification. And currently, the latest classification given is as 2020, and we realized that in last 8-9 years, that what we identify as seromucinous tumors are nothing but nothing but the part and parcel of endometrioid type tumors. They have the same, the most of them are associated with endometriosis. And again, that category has been thrown out. It is included in the part and parcel of endometrioid tumors. So it is interesting to see how our understanding has evolved over last 30 to 35 years. So again, the commonest being serous, mucinous, endometrioid, and clear cell type in the latest WHO classification. This particular table says the same thing what we discussed for last 2 minutes. So if you go on to the next, go on to the latest 5th edition of female genital tract tumors, the general principle and preamble of the classification tells us that this is intended for worldwide use. There are many areas where, for various reasons, application of immunohistochemistry and molecular pathology is limited. So standard aspects of conventional pathology remains a bedrock of interpretation and classification of female genital tract, or FGT, neoplasm in routine practice. Hence, to emphasize this, the essential diagnostic criteria for each entity are described, and these are the salient points mentioned in under ovary category. So the book mentions in ovary category, of course, there are in the preamble, we have comments, the salient comments about the ovaries, cervix, endometrium, and others. But I'm including 2 slides. These are the salient points described under ovary. So under ovary, we have serous borderline tumor with micropapillary architecture are included now as a broad category of borderline serous tumors. The term Madam Radhika mentioned about the non-invasive low-grade serous carcinomas, that term is not recommended. These tumors are indeed part and parcel of borderline ovarian tumors. So we must have, in short, we must have stromal invasion to call something as invasive carcinoma. If it is micropapillary areas, but no stromal invasion, it is a part and parcel of borderline serous tumor of ovary with micropapillary areas as a designation. We have low-grade and high-grade serous carcinomas are considered 2 different types of tumor other than a spectrum, because they have different origin, they have different morphology and different molecular and genetic signature. Endometrioid type of carcinomas of the ovary gives a linear classification in that seromucinous tumors are part and parcel of endometrioid tumors. There's a separate comment about small cell carcinomas of the ovary of hypercalcemic type. This is retained or rhabdoid cell tumor terminology. Although majority of them show SMART CA4 mutations, only minority show rhabdoid morphology, and this currently comes under miscellaneous group category. Initially, we wondered whether they are part and parcel of high-grade carcinomas. We also wondered whether they are part and parcel of germ cell tumors or sex cord tumors, but currently they are under miscellaneous group category, and we now know that they indeed represent a highly aggressive tumor, which is SMART CA4 mutation, resulting from SMART CA4 mutation. So typically ovarian surface tumors, we have benign, borderline, mucinous and malignant category. In that we have serous subtype, mucinous subtype, endometrioid subtype, clear cell subtype, and undifferentiated we have only malignant category. So what we are going to discuss are actually basically practice of surgical pathology, in that the histology cannot be read in isolation, and the surgical and medical knowledge of the histopathologist is required at all time. Madam Radhika stressed upon all the time that we must know the treatment algorithms so that we understand the implications of our diagnosis. So that is why the attendance of a pathologist at the multidisciplinary team meeting is actually vital, because it tells us what the implications of your diagnosis is. Sometimes we know that we are breaking our head where we are agonizing about a particular diagnosis subclassification, and that really has no bearing on the patient treatment, and what actually has bearing is actually different than what we are actually harping upon. So our attendance at multidisciplinary team actually is vital. Understanding of imaging findings, tumor markers, and ascites isoctulose is very helpful to coming to the diagnosis. More clinically significant diagnostic discrepancies are encountered in gyne-oncopathology than other branches of pathology, and this is from one of the articles from Dr. McCluggage, and hence the availability of relevant clinical data is crucial. But I understand that availability of clinical data and history is a challenge in many pathology labs, because the clinicians are not very forthcoming in giving us those details. In our hospital, we have electronic medical records, and that's why we have access to the medical records, tumor marker levels, and radiology as a convenience. But this can be a challenge, and we understand that. So our approach, or my approach to the classification of ovarian carcinomas or dealing with ovarian carcinomas, is that what about, I think the size, status of capsule, and cut section are most important to me. Size is obviously important because it tells you that there is a tumorous enlargement. Status of capsule, because intraoperative rupture or a rupture of a capsule by the tumor makes it, or of a carcinomatous cyst, makes it directly into stage 1C. For paraffin sectioning, we must have a proper fixation so that our assessment of morphology is much clearer, much better. And adequate sectioning is very important, especially I would say borderline mucinous tumors and immature teratomas of the ovary, because their adequate or extensive sampling is required to reach to the right diagnosis. If we have a say 15 centimeter tumor mass, which is obviously solid, have hemorrhage and necrosis, I don't think we will require 15 sections. But this is where a student should take help from the senior colleague, in that we may take lesser number of sections in that particular tumor. But if we are facing with the challenge of a borderline mucinous tumor or immature teratoma, I think we must take multiple sections as described and as advocated by the experts. So, for example, this is a tumor. Dr. Indu, can you see the arrow here?
Yes, sir.
Yeah. Okay. So, so this is particularly a tumor which has a papillary excrescence on the surface, and what we can make out is actually part of the capsule, but partly the capsule is breached in many areas. So this particular tumor, if it is carcinomatous on histology, this is clearly stage 1C at least. So the clues that I take from the grossing is that if you have a unicystic ovarian enlargement, we look at the cyst, where there's a serous content or a mucinous content. So if it's a unicystic ovarian enlargement, cystic, unilocular, it could be mucinous cystadenoma or a serous cystadenoma. If we have a cystic which is multiloculated, then the chances of it could be cystadenoma or it could be borderline tumor. If we have hair gross examination, that's why it is very important. It is mature teratoma. If we have solid, this particular image would make us feel that whether this is a borderline tumor of the ovary, there are papillary excrescences, not only within the ovarian contents of the cyst, inner surface of the cyst, but also on the external surface of the cyst. And Radhika madam showed just such a feature. We'll just briefly, 1 or 2 sections, dwell upon that. But this is looking to be a borderline serous tumor of the ovary. If we, on the other hand, have a solid tumor, a firm solid tumor, non-friable, could be Brenner's or a fibroma. Granular cell tumor can be firm, or metastasis can be also firm, but usually metastasis will have a mucoid hue. Against that, if you have a solid tumor, which areas of necrosis with areas of hemorrhage, they are likely to be malignant tumor. This is likely to be carcinoma or a mixed malignant mixed germ cell tumor. And I think that's why the gross examination is actually most vital for me to actually go ahead to suspect something. Because if we are faced with such a tumor on frozen section, we are not going to have more than 2 to 3 sections, maximum 3 sections. So I think this tells us or guides us where to take the sections from. Then coming to, I will have just 2 to 3 slides on borderline serous tumor, because Madam Radhika has extensively covered on this matter. Borderline serous tumors are non-invasive, low-grade proliferative serous epithelial neoplasms, and they account for 15 to 20% of tumors. There's a wide age range, and histologically and cytologically they are intermediate between clearly benign and clearly malignant tumors. And absence of destructive stromal invasion is the main thing that identifies borderline tumor from the benign tumor and the malignant tumor. There are peculiar issues like micro-invasion, implants, lymph node inclusions, peritoneal fluid involvement, and the terminology of non-invasive micropapillary serous carcinoma. Madam has just covered that. So this is an example of a borderline serous tumor, which is inside a peculiar papillary excrescences, and they're also on the external aspect. And these are the areas of micro-invasion in a borderline serous tumor. There are, the textbooks mention 4 or 5 different patterns, but by far the commonest pattern is actually this artifactual area, and which is not more than 5 millimeter in size. I think this is the last slide on the borderline tumor I will take, is that Madam described non-invasive implant, lymph node inclusions, and also involvement of serous papillary low-grade neoplasm of a peritoneal cavity. This is again in the part of borderline serous tumor with micropapillary areas. We do not call it non-invasive micropapillary serous carcinomas. Coming to ovarian serous carcinoma, they are the commonest type of epithelial malignancy, most present in high stage disease. About 85 to 90% are high grade tumors. They form glands, papillae. Some of my bodies are actually seen in approximately 40% of cases. So not necessarily we must have some bodies in all the cases. What is important is high cytological grade, slit-like areas, and papillary is actually one of the architectural pattern, but most, or in fact in many areas they can have only solid areas. We used to grade it as grade 1, grade 2, or grade 3, but currently the 2-tier gradal system is recommended. Mostly they are the high-grade tumors, and if combined with primary serous tumors, primary serous peritoneal tumors, carcinosarcomas, or mixed tumors, high-grade serous carcinoma will comprise of 75 to 78% of all the all the carcinomas, and 87% of advanced stage disease. Often we see that the patient presents with ascites, and often the primary diagnosis is based on ascitic fluid. Dr. Preeti just mentioned that to us, in that ascitic fluid cell block gives us a primary diagnosis, and then patient goes for chemotherapy. So serous carcinomas are divided into 2 distinct subtypes, low grade and high grade. The low grade are the ones which we have uniform nuclei, mild to moderate nuclear atypia. Mitotic count may be 1, 2, or 4 per 10 high power field. There's no necrosis, and there's no multinucleated tumor giant cells. As against that, high grade tumors are marked nuclear atypia. They show necrosis. Multinucleate tumor giant cells are often seen. These are the tumor giant cells described as trophoblastoid type tumor cells. Mitotic figures are definitely more than 12 per 10 high power field, and this is what is described in these two columns. Low-grade serous tumors often express ER, and possibly there is a therapeutic role, because sometimes you have a high stage but low-grade serous tumors, and if the surgery is a mainstay in that, And because they respond poorly, because the proliferative index actually is low here, 4, 5, 10%, and they may respond well to anti-estrogen therapy. And that's why medical oncologists may ask you, after giving a diagnosis of low-grade serous tumor, which is high-stage disease, they may ask you what is the ERP or hormonal status on histology. This is an example of a high-grade serous papillary tumor, which is hardly any papillae here, but slit-like areas are seen, mainly solid component is seen. Low-power view shows slit-like areas and solid component, but this is a high-grade histology. In fact, you can make out mitotic activity very well. There's no dearth of mitotic figures. In fact, atypical mitotic figures are also very well seen, and these are the multinucleated tumor giant cells which are seen in this tumor. They are typically CK7 positive, WT1 positive, and often the primary diagnosis is made on ascitic fluid cytology. Cytology shows high-grade metastatic adenocarcinoma, and cell block we can make out CK7 positive, WT1 positive, PAX8 positive, as well as P53 mutation type staining in high-grade serous carcinomas. And then they go on to chemotherapy, and usually after 3 to 4 cycles of chemotherapy, we get a sample actually of a THPSO of a definitive surgery rather than the first biopsy. Sometimes we get a biopsy of a high-stage disease of ovarian malignancy, and we will have the same immunoprofile, CK7 positive, WT1 positive, PAX8 positive, and P53 mutation type staining, thus giving a diagnosis of high-grade serous carcinoma of the ovary. As against that, we have a low-grade serous carcinoma, and the main point is that there is a serous ovarian neoplasm, but which definitely shows stromal infiltration. The stromal invasion is the main important thing. This has a multiple or pseudomatous calcification, but if you look at the morphology here, morphology is low-grade. Morphology is mild to moderate atypia. They may have, they will have lot of papillary formation. They will show stromal invasion. And these are the ones which are low on CRP2, they are low on BCL2, they are low on c-KIT, and they are also P53 wild type. They are also low on MIB1 staining index, so 4, 5, 7, 8% MIB1 index, but they do show ER and PR positivity. So these are the low-grade serous adenocarcinomas. They are invasive neoplasm by definition, but they are approximately a decade younger than the high-grade serous cancers. A small subset of patients may have a prior history of serous borderline tumors. Most exhibit KRAS or BRAF mutations. They are more indolent clinical cause than high-grade serous tumors, an excellent prognosis when confined to only ovary, and response to chemotherapy is actually less favorable. Hence, medical oncologists may ask ER/PR status, and it will be a good practice in low-grade serous carcinomas, and or it may be low-grade, low-stage or high-stage disease. It may be a good practice to provide ER/PR status on histology on this patient. So this is an example of a biopsy diagnosis of a low-grade serous tumor. So we have a ovarian enlargement. We also had extra ovarian disease, but if we look at the biopsy, we show we are seeing an invasive carcinoma indeed, but there's a lot of pseudomatous calcification. There is a stromal infiltration. There's no doubt about the invasive tumor. But if you see the histology microscopically or cytologically, they have low-grade atypia. PAX8 is positive, WT1 is positive, but MIB1 actually is low, and they are ER positive. So this is indeed a low-grade serous adenocarcinoma. This is invasive carcinoma, but this is low-grade serous adenocarcinoma. Coming to mucinous carcinomas of the ovary, they are in the WHO defines it as invasive mucinous neoplasm composed of gastrointestinal type of differentiation. They account for 3 to 4% of all primary ovarian tumors in North America. The median age is 55 years of age. Can show continuum from benign looking borderline to carcinomatous area. So a benign looking area does not exclude a carcinoma. We must sample it more extensively. And if we see a definitive carcinomatous area, it is indeed a mucinous carcinoma of the ovary. There are 2 different patterns of invasion, and this actually is prognostically important regarding expansile pattern or an infiltrative pattern. But the most important prognostic pattern, most important point actually is the stage of the disease. Currently, there is no standardized grading system. In fact, meaning do we grade it as low grade or high grade, or do we grade it as grade 1, grade 2, grade 3? WHO does not give us a grade. So if we can make we can make a statement about expensile pattern or infiltrative pattern, I think that's one important thing. And obviously, the stage of the disease, depending on whether it's confined to the ovary or extra ovarian disease, actually that's the most important thing. I think the all of us have the question whether it's a primary or a secondary. That's even more difficult question. So important. We will see some examples of mucinous adenocarcinoma of the ovary. This is invasive tumor, mucinous differentiation. Sometimes the mucin may not be very evident in some of the areas, but in many areas mucin will be evident. And this is an example of a mucinous adenocarcinoma, high grade, depending on the cytological atypia. So the main question comes in our mind is in the mucinous adenocarcinoma, whether it's a borderline or a malignant. And this question is answered, or we try to answer by gross examination, taking more section from the solid areas, or step cuts to see the infiltration in the stroma. The most important thing is whether, if we are looking at a mucinous carcinoma of the ovary, whether it's a primary or secondary. And that's where I think we have to resort to immunohistochemistry. I resort to what are the Mullerian markers such as PAX8, CA125, ER. Let's say that CDX2 and SADB2 will tell us about the GI tract primary. But I will again draw your attention to the basic definition that WHO has given us, that the borderline mucinous tumors are the tumors which show gastrointestinal differentiation. So these CDX2 or SADB2 positivity doesn't really help us in any 100% way. They are just pointers. And here, use of radiology, use of tumor markers, if the serum CA is high, if the serum CA99 is high. But if there's on the radiology, there's an obvious tumor elsewhere, such as appendix, gallbladder, or pancreas, it might help us. And I must confess that in this distinction, maybe 70-80% of the times, if you have clear-cut PAX8 positive, CA125 positive, we have given a diagnosis that, okay, this is a mucinous adenocarcinoma, this is a moderately differentiated mucinous adenocarcinoma, and this is primary ovary based on PAX8 positivity. But that may not be possible in some cases, 20-25% of the cases. And we will leave that for the multidisciplinary team meeting as a joint discussion, that if there is on the radiology, what does the tumor marker say? And we say that, okay, there's a still chance that we may not be able to categorically say this is primary or this is secondary ovarian tumor. And I think the medical oncologist, in their best judgment, will give the chemotherapy, whether this is a ovarian type therapy or a gastrointestinal tumor type therapy. So there will remain a subset of patients of mucinous adenocarcinomas involving the ovary, which we are not able to categorize specifically whether it's primary or secondary. So best judgment is actually on the multidisciplinary discussion here. So this is a female of 36, an example of a ovarian tumor. We have these small glands, very minimal atypia here, kind of edematostoma in between, but a lot of this showed ovarian enlargement, this showed solid areas, and this showed mucoid cut section. But in other areas, there are mucinous epithelium, which is more higher grade in nature cytologically. There is a gland fusion. There are some necrotic areas. So this was a CK7 and CK20 positive. We did consider primary coming from somewhere else. And a stomach biopsy indeed showed a mucinous adenocarcinoma. So we concluded that this is a gastric adenocarcinoma with secondary involvement of the ovary. So primary ovarian endometrial adenocarcinomas, we do try to take help of CK7, PAX8, ERPR, and CA125. And metastatic colorectal cancers will be CK20 positive, CDX2 positive, SATB2 positive, and of course negativity for PAX8 and CA125. So this is an example of a female of 40 right ovarian tumor. We have a high-grade tumor adenocarcinoma. This is CDX2 negative, CK20 negative, CK7 positive, WT1 positive. This did show P53 mutation type staining. So we concluded that this is mutation types P53 staining. And we concluded this is a primary ovarian tumor rather than secondary tumor. One example, I think, one observation that I would like to stress is that in the secondary ovarian tumor, we do see actually normal edematous ovarian stroma in between. So if we look at this area, these are actually mucinous adenocarcinomas of the ovary. But on high power, we see these abnormal glands. Some of them are actually signature cell appearance. And in between, we are seeing normal ovarian type stoma. This actually, to me, the most important feature to suspect metastatic adenocarcinoma. And these are CK7 positive, CK20 positive, CA positive. This again also showed a primary in the stomach. What I'm trying to say is that I think primary mucinous adenocarcinomas of the ovary will not show, or at least they are less likely to show a normal ovarian mucinous, a normal ovarian stroma, ideomatostoma in between, whereas secondary tumor of which is mucinous in nature shows us the normal idiomatous ovarian stroma in between. This is just an observation and perhaps an helpful point towards picking up mucinous secondary tumor to the ovary. Coming to endometrioid carcinoma, they are the resemble endometrioid adenocarcinomas of the uterine corpus. Mean age is 55. Most tumor are originate from endometriosis. Squamous differentiation is common, and mucinous differentiation can also be seen. Seromucinous carcinomas, as we described earlier, are now considered subtype of the endometrioid carcinomas. Clear cell carcinomas of the ovaries are composed of clear and eosinophilic or hobnail cell. This is a typical pattern, tubulocystic pattern, hobnail pattern. They are by far the more commonly associated with paraneoplastic syndrome, such as hypercalcemia or venous thromboembolism. Typically, they are positive for Paxate, Napsin, and HNF-beta, and negative for WT1, ER, and PR. So this is an example histology of a tubulocystic pattern of a clear cell carcinoma of the ovary. Clear cell carcinoma of the ovary. Hobnail pattern actually is most characteristic here. The cytoplasmic clearing is seen in part of the tumor, may not be seen in all the areas, and they do show intracytoplasmic eosinophilic globules. Mind you, this is also a feature in yolk sac carcinoma of the yolk sac tumor of the ovary. So if this is seen, this is well and good. If it fits well with the epithelial marker, EMA positivity, Napsin positivity, this is indeed a clear cell carcinoma of the ovary. But only this feature in the young age, in alpha fetoprotein high, this can be a feature in yolk sac tumor of the ovary. So the context is actually most important here. Going on to a particular example of a 22-year-old female ovarian mass, which we got it for frozen section. We thought this is a high-grade carcinoma of the ovary, but typically what we are seeing is that intermediate type cells, they are small groups, typically multicystic areas, idiomatous ovarian stroma in between, friable, necrotic area, LDH 361 units, and this was the one which we thought whether this is germ cell tumor or something else. And this was indeed a high stage disease even to start with. They are intermediate size cells. And when we did BRG, we did think of small cell carcinoma of the ovary, and BRG was negative in this tumor. So small cell carcinoma hypercalcemic type is a peculiar tumor which is now put in the miscellaneous category. They are the undifferentiated tumor composed of small cells with or without a large cell component. Some of them actually can have large cell component, which can have rhabdoid type morphology, and that's why they are called as they can have large cell component. They are often associated with hypercalcemia, but to be honest, we have encountered about 3 cases, and none of them was associated with hypercalcemia. Our colleague Dr. Ayushi Sahai wrote it up case report with two cases. Textbooks mention that 1/3 of them can be associated with hypercalcemia. They are unrelated to small cell neuroendocrine tumors of pulmonary type. They usually are seen in young age. They usually are high stage disease at presentation, and somatic or germline mutation in SMART-CA4 gene is almost all tumors. So this is the diagnostic feature in these cells. They can show sheets, nests, cord-like areas, follicle-like spaces. So you may wonder, this is a neuroendocrine tumor, but this is not a neuroendocrine tumor. And you see the immunohistochemistry profile here, which is actually most confusing. They have EMA and CK positive, which is like a carcinoma. They have P53WT1 positive. This is like a serous tumor, P16 positive, but they are very, very positive for calretin, inhibin, neuroendocrine markers. So this can be actually most confusing, but the defining feature would be actually BRG deficient tumors. So BRG is one of protein which coded by SMART-CA4 gene. So this is present on chromosome 19 and encodes enzymatic subunit of SNF complex. So loss of BRG1 expression, this actually is, or inactivation is a defining feature of this tumor. But along with this tumor, there are certain other type of tumors which could be BRG1 deficient. And this particular BRG1 as well as INF1, I think are coming or proving to be a specific entity because they are not only in ovarian tumors, they are also seen in thoracic sarcomatoid tumors. They are also seen in pulmonary carcinomas. They are also seen in some of the uterine undifferentiated sarcomas. And why are we trying to identify these separately? Because there will be separate, actually, a targeted therapy will be available on these, which are EZH2 inhibitors, which targets these smart CA4 or smart CB1 deficient tumors. So the idea of identifying these is that they are indeed actually high grade, high stage tumor, extremely aggressive tumors. And but there's something actually possible to be done on this as regards to the therapy. Few studies have also suggested efficacy of immune checkpoint inhibitors in these tumors. So going on to frozen sections and ovarian tumors, the general philosophy is that usually ovarian organ enlargement is restricted to ovarian. That's where we do frozen section, because the aim is fertility preservation in say for example sex cord tumor in the young, germ cell tumors in young, borderline serous tumors in young ladies. And the questions are posed for the pathologist is that, is there a malignancy or no malignancy? If there's a malignancy, what is the type of malignancy, whether it's a carcinoma or germ cell tumor, or can you say something? The issues for us is adequate sampling should be done, but the frozen section can be busy and we can't actually take more than 2, 3 or maximum 4 sections, perhaps 3 sections. So here, I think my algorithm, what I suggested, I think many people use that algorithm of gross examination, taking adequate, most relevant 2, 3 sections, and coming to a diagnosis is actually most crucial because you don't have much time. You have 15 minutes to give an answer. So limitation to sampling is actually an issue. So if malignancy, whether it's a primary or secondary, this is the most important question by the oncologist or gyne-oncology surgeon, because if it's secondary, they are not going to perform THBSO, mentectomy, lymphadenectomy as you would do for a primary ovarian tumor. But if it's a primary, it is actually, that is extent of surgery is a limitation. If it's a mucinous borderline tumor, look at the state of the appendix. The surgical current guidelines state that if the appendix is normal, you may not remove it. If it's swollen, obviously you will remove it. And from pathology examination point of view, you will have to examine all the appendix histologically to check for whether it's appendicular primary or mucinous tumor is a secondary. Of course, if we have inflammatory mass, COX, or any other PID-related disease or chronic inflammation involving the ovary or tubo-ovarian mass, if we can give that diagnosis that this is inflammatory mass and not carcinoma, that's good news for the patient. Good news in the sense the extent of the surgery is limited. Whether fertility and the patient can conceive or no will be actually a clinical doubt in this matter, because extensive involvement by COX of the tubes or the ovary will not be a good news for the patient from the conceiving point of view. But malignancy point of view, at least we have given some answer that this is not malignancy. So coming to, we have done a gynae pathology frozen section audits. We looked at, distribution of accuracy of frozen section reporting gynae pathology over a period of 3 years' time in our institution. This was presented as an abstract of a European Society of Pathology conference, but due to maybe my laziness, this has not been converted to a paper. But I think this has relevance to what Radhika Madam showed us some of the papers. In that our frozen section service is actually very busy because we have a lot of head, neck, and breast cancer work. So totally we do about 4,500 frozens, and gynae pathology frozen sections will be about 7 to 8% of those frozen sections that we do annually. So what we try to do is we looked at the reports. Actually, we looked into the reports of 920 frozen sections pertaining to gynae pathology. What we found out is that primary diagnosis of the adnexal mass was a commonest specimen and constituted 43% of the total gynae pathology frozen sections, followed by pelvic node examination for metastatic and cervical cancer studies. So most common was adnexal mass frozen. Then common was lymph node status, 25%. Then common, which was 11 to 12% of the depth of myometrial invasion and cervical involvement in endometrial adenocarcinomas. Other frozen section requests were, deposit over omentum, deposit over sigmoids, pelvic mass biopsy, urinary bladder, etc. The discrepancies we divided into major and minor. Major would be lead to some change in the action during the surgery, and minor, which, subtyping of carcinoma or fibroma, leiomyoma, this will not change the plan of action. So this is the same thing. The commonest was adnexal mass, 43%, then common was pelvic nodes, and depth of myometrial invasion followed. So the overall agreement between FS and paraffin section was 86% considering all discrepancies. We have not actually examined individually only ovarian or only endometrial or only cervical, but commonest, overall agreement is 86%. It is not 100%, and this is a limitation that Radhika madam stressed upon, that oncologist or surgical oncology colleagues should realize. We do discuss very commonly multidisciplinary team meetings. If we get and this is where I think if we try to be actually most strict, then this is 86%. Probably if our 1 hour audit records is about 92%, probably the figure is 88 to 90% in our hands. And this is everybody, all our faculty members see frozen section in rotation. So this is perhaps a more realistic consideration, that frozen section in gynae pathology, including everything, is about 86 to 88%. I think we can skip these slides. These are the breakup of the frozen sections. So inferences was a primary diagnosis of adnexal mass, the commonest, followed by pelvic node, and depth of myometrial invasion was the next common. I think we can go on to the next topic, and this is the last few slides. So what do you do in frozen section in a ovarian tumor? So this is the frozen section slide on the left side. I generally want to look at the gross myself, take sections myself, and then I will try to look at the slide. So this particularly on the left side, my impression would be there are papillary excrescences here on the inner aspect. The capsule looked quite fine. It was not breached, but this looks to me actually more than cystadenoma. There are excrescences here. So this is probably the borderline serous ovarian tumor, and this is what is reflected on the right side on the section. This is one of the 3 sections. All the sections look the same. So we gave a diagnosis of borderline serous tumor of the ovary, await paraffin section report. Usually, if you give a borderline report, I think we will add a note, a borderline report, borderline serous or mucinous report, and await paraffin section report. So young ladies, tumor markers for germ cell tumors will be checked. Measurement, external surface and capsule, unilocular or multilocular. Multilocular is our suspicion for borderline tumors is high. Are the content serous or mucinous? We'll take about 3 sections. And if we are convincing, then we report carcinoma. Otherwise, we will stay at least borderline or borderline. I think general philosophy here in the young ladies is that if you're not sure about infiltration of the stroma on frozen section, 2 or 3 slides, I would rather be cautious and be call conservatively borderline tumor and await paraffin section report than to overcall and be bold or blunt to call it carcinoma. With if I'm not sure, I will not call it carcinoma in frozen section slide. Usually, when the report will be given as borderline serous tumor of the ovary, stromal invasion is not seen. Await paraffin section report. Another example of a slide, and you would look at our Madam Preeti is laughing, smiling. This is our. If you look at our algorithm on the gross examination earlier, this particular tumor I think will require extensive sampling. It looks mucinous on cut section. Maybe there are some thickened septae, but this is obviously multiloculated. Our gross examination impression would be actually borderline mucinous tumor of the ovary. This did show, we did take 3 sections. We called it borderline mucinous tumor of the ovary. There was no obvious infiltration on the stromal invasion on the section. So we ended up calling this was the sections. This is actually the frozen section slide photo. So we have stratification, we have some goblet cells, we have some amount of mild to moderate atypia. But if you see the stroma, there is no stromal infiltration here. So the report went out as a borderline mucinous tumor of the ovary, await paraffin section report. We will look at the surgical team status of the appendix during the surgery. We will look at the tumor markers, just in case there is anything which comes up as a serum CA enlargement. Is there anything which is suggestive of any extra ovarian primary organ enlargement such as appendix or pancreas or gallbladder. But if that is not seen, we will send out report as mucinous borderline tumor of ovary, await paraffin section report. So coming to last two slides, adenoma, borderline or carcinoma terminologies are important for understanding as they have different prognosis. In mucinous borderline tumors, ovarian tumors, we need reasonably to exclude secondary. Extensive sampling is important for epithelial mucinous tumors or mature teratoma. I think that is my take on the variegated appearance or the extensive sampling. Close attention to gross appearance helps in developing algorithm, and we just discussed about the algorithm in initial first few slides. Stromal invasion is important in diagnosis the invasive carcinoma, and even WHO has stressed that the micropapillary non-invasive carcinoma is a term which is not recommended. We must see stromal infiltration to call it micropapillary serous carcinoma or indeed any type of carcinoma. So morphology gives a clue to the diagnosis in overwhelming majority of the cases. But I do believe, and I'm a firm believer in extra sections, deep cuts to arrive at a diagnosis, or at least giving hints or examining the stromal infiltration. Fertility preservation is a very important point if we are looking at the frozen section in a young. So I think the conservative approach is not. I mean, it's not a shame to have a conservative approach. If somebody criticizes me, this looks like a carcinoma, but if I'm not sure of stromal invasion on frozen section, I will not call it carcinoma. It is actually better to operate at a second stage rather than to give overcall carcinoma and final diagnosis cystadenoma or borderline tumor. I think that's not advisable. Immunohistochemistry is used to confirm the diagnosis, to rule out a close differential diagnosis. And sometimes it is also useful for therapeutics in the sense if you give ERPR, that gives the therapeutic options to the medical oncologist. But rarely, our knowledge always is actually evolving with immunohistochemistry. Rarely they are 100% specific. So use panel and believe in actually when somebody says, okay, this is absolutely specific, I think take it with a pinch of salt, because c-KIT is a marker for gastrointestinal stromal tumor, but c-KIT is also another excellent marker for melanomas. Excellent marker is actually can be a good marker for neuroendocrine tumor. It is an excellent marker for dysgerminomas. So nothing is specific. A panel is actually more useful. Of course, specific ISC markers such as BRG1, one looking at a prostate, you are looking at adenocarcinoma, which is prostatic origin or something else. So such specific markers are indeed useful and they're required for specific diagnosis. So if you are, and obviously lymphomas, immunohistochemistry will be actually mandatory. So with that, I think we end the discussion on the carcinoma of the ovary. I'll be happy to thank you all for your patient hearing, and I'll be happy to take any questions or comment. Rajan sir, yeah. Sorry, Preeti madam, yeah.
There were a lot of questions, and it seems that Dr. Bharat has written answers for many of the questions.
Okay. So Dr. Bharat has answered, so that's fine. Yeah.
And thank you, Dr. Kedar, for this elaborate talk beginning from classification to frozen section and covering rare tumors like small cell carcinoma.
Right.
And one question is, please comment on the confluent pattern of invasion of mucinous carcinoma.
Confluent pattern actually is that's usually the more commoner pattern which is described, but for which we need to have multiple sections. Confluent pattern is something similar to what we see in endometrium. We have a lot of confluent or a lot of gland fusion, but not individual gland is showing kind of a straightforward stromal infiltration. So that is by what we understand by confluent pattern. It is a general term. As against infiltrative pattern, which is shown by individual invasive gland or indeed some of the tumor nest.
Then another request is to share your experience on Krukenberg tumor.
I mean, Krukenberg meaning generally we're talking about metastatic ovarian tumor. So in clinical context, if there is a known, I'm always thinking from the point of view of as patient comes to the OPD and we are involved in multidisciplinary team discussion. If there's an obvious biopsy proven carcinoma such as stomach cancer and ovarian enlargement, ascitic fluid is there, I think that particular patient biopsy may not even come to us. because clinically they have a proven gastric cancer, say CA is high. Such patient will go for chemotherapy based on GI malignancy, FOLFOX-based chemotherapy. We come into the picture when we have a unexplained ovarian enlargement. There is ascitic fluid. We tap ascites, we diagnose carcinoma, but the cell block shows carcinoma which is of GI tract origin. That's where we come to the picture, or you come into the picture when we have a ovarian biopsy and there is an extra ovarian disease and we have a adenocarcinoma which is CDX2 and positive, but PAX8 ER of CA125 negative. That is when we come into the picture, or indeed rarely you get a primary ovarian excision on your table and you are looking at whether this is a granular cell tumor or Brenner tumor or metastatic tumor. And there I think our role actually is most crucial in frozen section. If I see the adenocarcinoma and if I see actually the normal edematous ovarian stroma in between, I think that is a very good helpful clue to suspect secondary tumor. So if you get such a tumor as a ovarian tumor on your frozen section slide, the diagnosis of mucinous adenocarcinoma will probably be the first step, and that hopefully that is not difficult. But second step is always a gynae oncologist wants you to say whether it's a primary or secondary, and these are the few points which will help you to say primary or secondary. Of course, if we can say that, we say favor primary or secondary, favor secondary or primary. If we can't say that, we'll say okay, we can't say it. But most of the times, serous carcinomas, endometrial carcinomas, we can say favor primary, and most of the Krukenberg tumor, we will be able to say favor secondary. But here, I will add that I will look at the serum CA levels, tumor marker levels, in order to suggest or support any other primary diagnosis in GI tract. So that's what it is really. Yeah.
I just add a little bit on to what Dr. Kedar has said.
Sure. Yeah.
Yeah.
Yes, ma'am.
Yes. Thank you, Kedar, for that very extensive talk.
Thank you.
Which is very nice. But I was just wanting to add to what you said. In Krukenberg tumors, we have had a few Krukenberg tumors occurring in young women in their 30s, and they have always been so challenging to diagnose. And in fact, when we did an audit of our own frozen section service in gynec oncology, we had made mistakes. We had not picked up, we had about 3 cases which occurred in women in their late 20s and 30s, Krukenberg tumors. All of them, we had missed the diagnosis on the frozen, simply because, you don't consider Krukenberg at such a young age. And I think we had called them out differently as sex-cord stromal tumors. In one, we had called possibility of a germ cell tumor also. So it can be very, very challenging and in diagnosis, especially on a frozen. Now, even when you have the permanent sections and you have a Krukenberg, when the patient is young, of course, extensive investigation will have to be carried out, endoscopies, etc., etc. Because again, IHC to pinpoint the primary is, they're just so non-specific that ultimately an extensive, thorough workup has to be done in the patient to actually detect the primary. And I think majority of the cases, they would detect a stomach rather than a colorectal primary, particularly in, in our setup. This is what has happened. Yeah. So third thing is regarding this ERPR, somehow our clinicians are not, into asking ERPR and borderline serous tumors. Even recurrences in borderline tumors are generally the best treatment is again second surgery. It's only when for some reason surgery is not possible. Nowadays, what is happening is they are asking the paraffin blocks to go and do an NGS, for example, to look at again certain targetable mutations. But even there, most of the time, nothing is found. I mean, even the only thing that can be targeted may be a BRAF, but that again, many times is not found. So again, we have seen a few patients who've had recurrences of borderlines, particularly serous tumors, and the treatment again is a second surgery. In one case, even up to 3 surgeries this lady has had. In our setup, the frozen section indication is a little different from Tata. Majority of it is ovarian. I would say 90% of our frozen requests are for ovarian mass. And a good number, at least 80% of them would be young women, where the dilemma is whether to go for conservative approach or whether they have to do a completion surgery. So when they take up such cases, everything is of course explained to the patient. Most of the time, quickly they communicate to us what they want to know, whether it's benign versus borderline or borderline versus malignant, or sometimes rarely whether they just want to know is it germ cell or epithelial. So all these have been some of the slight differences, I think, institutional wise differences that can exist. So everybody's practice areas, practice environment would be different, and the indications would differ from place to place, I think. Thank you. Over to you.
Yeah, thank you, ma'am. Thank you, ma'am.
Then another question, Dr. Kedar. In mucinous carcinoma also, there should be retraction artifact to say there is destructive stromal invasion.
No, actually, destructive stromal invasion will give you more of a fibrous or stromal reaction, rather than retraction articefacts. Yeah, but it is a very uncommon pattern.
I agree completely with the Kedar there, that the message is that in mucinous carcinomas, it's most of the time it is this expansile growth pattern. You don't see that stromal destructive invasion at all. So expansile pattern of invasion is what you see. Expansile growth pattern is what you see. Then you also look at the cytology. When you see high-grade nuclei, when you see kind of luminal necrosis, you see fragmentation of glands, you kind of sometimes also see mucin leakage into the stroma. All these are telling you that it is malignant. And so mucinous carcinomas, you don't see that typical retraction artifact that you see it in serous tumors as a point of.
Then another question is the best IHC panel to differentiate a primary ovarian mucinous carcinoma from gastric bar colonic metastasis. There is no ideal one, no?
So you can use actually backside ER CA125 is actually useful to suggest what we are dealing with a Mullerian type of tumor. I do use CK7, CK20, but CK7, CK20 doesn't really help us because mucinous tumors of the ovary will be CK720 positive. But suppose say CK7 is negative and 20 is positive, then I am more in favor of a GI tract tumor, and I will add CDX2 and SADB2. But I think I'm more relying on nowadays Paxate, CA125 ER to actually kind of say it is Mullerian in nature. It may not help in all the cases, but if it helps, I am more confident to call it ovarian primary rather than secondary.
Okay. Then another question is, when you have concurrent endometrioid, ovarian and uterine, if no endometriosis is seen, how to differentiate? And should that be graded separately?
It's actually, the textbooks mention that if both are low grade in nature, if the endometrial tumor is not deep myo-invasive, it is stage 1A, and there is no LVSI. Suppose say, and secondly, the ovarian tumor also is endometrioid and low grade in nature, then I think they both can be treated as independent primaries rather than two separate secondaries of one mets to the other. That's what the textbooks have said.
Madam, can I just add a little bit here, Kedar?
Yes, ma'am.
Yeah, actually, I think there has been some studies in this direction. And yes, we always debate whether they are concurrent primary tumors, or one is if it's ovarian primary with uterine mets, or the uterine primary with ovarian mets, of course. But when we have similar looking tumors in the ovary as well as in the uterus, based on several molecular studies in the recent past, I think Navina Singh had a review article on this aspect. And a good majority of them are actually primary uterine tumors with secondary deposits in the ovary. And it is also believed that a good number of these deposits occur through the transtubal kind of tumor goes and gets deposited into the ovarian surface and then mimics like an ovarian kind of primary. So the bulk are uterine primaries with ovarian metastasis. Only in a minority would they be actually synchronous double primaries. Majority would be uterine primaries. So this is one, I can't give you the exact, maybe it came in histopathology. There was a review article. And Navina Singh was one of the authors which has looked into this aspect. Over to you.
The WHO book has mentioned that they are actually indeed clonal in nature, both these tumors.
Correct. So, but they have found that that's why uterine is the primary and the ovary is the metastasis.
Even ma'am, the European guidelines of the radiation oncology and medical oncology have said that. But in the end, they have said that they should be treated as two independent primaries. That's the clinical guideline.
Yeah. So basically, the reason is you don't want to over-treat them and put them into a higher stage, because even if it's a uterine primary and ovarian deposit, the treatment should be as for a low stage two primaries, that is both of them being lower stage, and not like an advanced stage endometrioid carcinoma of the uterus. So that is the message that has that has been given. And I wrote to Dr. Indu and Preeti also that there are these ICCR data sets which can be downloaded by the audience. You can sit in here, you can download it on your phone. Apart from the synoptic reporting formats, what you also get is, following that, you have something called explanatory notes. So those explanatory notes are actually updated periodically. Every couple of years they're updated. I mean, you have it for everything, not just female genital tract, for everything. And if you want a quick reference, you don't want to go to PubMed and keep searching. Quick reference, these are very useful. And the organizers of this conference can actually disseminate the ICCR datasets for the female genital tract to the audience. They are just PDF files and you can circulate them. Over to you.
Thank you, madam.
Okay, thank you, madam. Dr. Kedar, you are using CA125 also along with Paxate to say whether it is Mullerian or not, no?
Yeah.
You use both of them together?
No, these two are the ones which are available to us. In a mucinous tumor, I do use both. Or if I don't have sometimes what happens is there are limitations to how many antibodies that you can use in a particular case. Then our first choice is actually Paxate. Second choice is CA125.
Okay. Then when you don't get a Paxate, you will do a CA125 also when you are suspecting Mullerian.
Yes. Basically, the attempt is to decide whether Mullerian primary or secondary.
But madam, Paxate works very well. Number one.
Yes.
CA125 as an IHC marker is useless. It is very non-specific, never recommended by any expert in any data set. My take on this is, sorry, but it's little different. I'm really sorry. I don't want to come in butt in like this. I apologize to you people, but Paxate is the only Mullerian marker. CA125 is a very good serum marker. It's not a marker to be used in IHC. It will be misleading. Okay? Because it comes up in a whole lot of GI malignancies. It's very, very non-specific.
Thank you, madam.
Don't use it as an IHC marker.
Ma'am, I think I've used C125 and I think I found it useful to say it is.
Kedar, maybe personal experience first, but experts don't recommend it. That is what I said.
Initially, we too had used it in a couple of cases and then we gave up. Then another question is, when we are suspecting endometrioid adenocarcinoma on morphology and Vimentin comes negative, how are we going to approach the tumor?
This is an ovarian tumor.
I think so. It has to be, no?
If on morphology you think
it could be uterine too. It could be uterine, I think.
What I mean is, if it's on endometrioid carcinoma on morphology, I will not give too much importance to Vimentin, negative or positive. I think if I want to see the endometrioid morphology, squamous differentiation, mucinous areas. So if that morphology is solid, I think I will call it endometrioid adenocarcinoma.
And Vimentin can be focal, sometimes in endometrioid adenocarcinoma.
I may not
use it.
I want to actually, if it's an ovarian carcinoma which is high grade and which has more endometrioid in nature, I would rather do WT1 and P53 to exclude serous carcinoma.
Okay.
So if I'm looking at endometrioid carcinoma and if I'm solid on morphological criteria, I think we should call it endometrioid adenocarcinoma. I don't think I use actually Vimentin to particularly diagnose endometrioid adenocarcinoma.
Okay, thank you.
Preeti,
Yes, Indu.
Preeti, can I? Yeah,
Okay,
can I?
Okay, Indu.
Yeah, can I ask a question regarding
Yes,
the
please.
IHC marker?
Yes, please.
What is your experience with napsin on clear cell carcinoma, Dr. Kedar? Do you
It's very
find it?
good. Napsin actually is very good in the sense, I mean, that HNF1 beta we tried long back, but it's not worked in our hands. But napsin is actually useful. I use it actually to diagnose clear cell carcinoma. Of course, clear cell carcinoma if I have a right morphology, I'm fine. If it's a very young patient, then I think one may think of a yolk sac tumor, but I think that's not a with the right clinical context. Clear cell carcinoma, napsin is fine. Only occasionally, may 2-3 times, napsin is negative, and you still strongly feel it is clear cell carcinoma. At that time, I have used Amacur. Amacur is one other other factor which can be used for clear cell carcinoma. But I mean, it's the kind of last resort.
Okay. And then another I would like to add is you can get napsin positivity in clear cell areas of endometrioid carcinoma. And we had one case of ordinary endometrioid carcinoma that was napsin positive. Right. So for the diagnosis of clear cell carcinoma, morphology is very, very important.
Yes, agreed, absolutely.
So finally, morphology is
very, very important.
Yeah. Thank you.
Can I just add in a point? I don't know, somehow got. So we worked on actually napsin A as a very useful marker and a good substitute of hepatocyte nuclear factor, which is ideal for clear cell carcinoma. It actually comes in a very useful way in identifying, different patterns of when we published about our 50+ cases in APMIS, So that's a good substitute. Having said that, you can see even in some endometrioids. So I think we need to know, and the residents don't know that comes as a very granular, like a very dirty granular pattern, but it reinforces clear cell in a vast majority of cases. I just got disconnected suddenly, so I think Dr. Kedar must have mentioned about it, and I do echo its utility across the entire female genital tract, which international audience apparently is kind of divided because they don't, some people, because they feel that it's, hepatocytes is the best, or maybe, but I think napsin is quite useful for cervix or ovarian or endometrioid to reinforce, but we need to know. So I haven't seen actually coming in serous carcinomas where WT is useful. So that's a good, sort of balance about napsin and WT1 to sort of look at the clear cell versus serous carcinoma. Just thought I'll just add to it. Thank you.
Thank you, sir. Thank you.
One more thing. Yeah, I also would agree that napsin comes strong, but remember it's patchy, it's granular, but although it is patchy, it comes very strong. It's definitely useful for clear cell carcinoma anywhere in the female genital tract. Of course, you have to look at it contextually, whether your question is, am I looking at clear cell areas in what is otherwise an endometrioid carcinoma, or is it a clear cell versus a serous? Then you choose your panel wisely. Over to you.
Thank you, Kedar, sir.
Okay, thank you so much.
Okay, thank you all for the active participation. We are running short of time, and so we'll wind up.
Thank you, ma'am. I'll stop sharing the screen, and the next speaker can take over. Yeah.
So, respected teachers, senior colleagues, and dear graduates. So it's my honor to offer the word of thanks after the successful completion of our 2-day webinar series. So I, on behalf of IAPM Kerala, would like to extend my sincere gratitude to the distinguished speaker, Dr. Diana, Dr. Santosh Menon, Dr. Bharat Regi, Dr. Mihir Gudi, Dr. Radhika Srinivasan, Dr. Kedar Deodar, and Dr. Sandeep Mathur, who have been with us for the past 2 days, sharing their vast knowledge and enlightening us with almost the entire spectrum of the FGS system. I think we have covered most of the WHO topics where we had difficulties like borderline tumor. We had a very fruitful discussion. So this was a very successful webinar, and we had a very crash course on the entire FGS system. I also like to thank our esteemed moderators, Ajit sir, Sadi madam, Dr. Sunitha Thomas, Indu madam, Dr. Preeti TR, and Dr. Laila Raji ma'am. And a special thanks to be mentioned to Indu madam and Adit sir for your endless support and for being the cornerstone of this webinar. And I'd like to thank the Mindray India team who providing us this platform, and because of whom this webinar could have been conducted. I think they were with us from the with us for every step of the way. I think from brochure to even to ensuring that this webinar is broadcasted throughout the India and outside. Special mention to Mr. Nikhil Sharma and the entire technical team. Thank you. And last but not the least, the chapter would like to show their deep felt appreciation to all the members and the pathologists and the postgraduate across the team who made this into a grand success. So, and I invite Rajan sir to share a few words.
Yeah, it's an aggressive sessions, 4 sessions. Okay, anyway, we are it's very interesting also because all the stalwarts in gynec pathology is there, and they are interacting, and the postgraduates and the chapter members gain a lot, I think. And one thing I want to tell you that 2 of my fellow chapter members helped me a lot. Indu from Amrita Institute of Medical Sciences, she was the pillar. She selected the topic, she selected the speakers, and it's just my duty to organize it. That's all. And along with Ajit Nambiar also is helped me. Any webinar, he is actually helping me a lot, and this time also he helped me a lot. And the role of Mindray India is again, because it's the 3rd successive webinar we are conducting together, and I am very confident in their support, the technical support they are given. I am very thankful to Mr. Nikhil as well as Shema, who is actually with us for the entire 3 weeks for this webinar, brochure preparation, everything. And thank you, Mindray India, for the support that is given. And thank you, the chapter members. Thank you, the members across India, and some foreign pathologists also are there outside India. So thank you for your patient listening. And I think that this 2-day webinar throws some light on the coming slide seminar topic that we will discuss on our chapter meet on August 28. Thank you very much. And you know that we are day after tomorrow, we are celebrating our 75th anniversary of independence. Annie, let us wait for the national anthem.
शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जगत मंगलदायक जय हे मानव भाग्य विधाता जय हे जय 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 जय.
So thank you all.
Thank you, sir.
Yeah. Thank
Thank
you,
you, Dr. Annie.
Thank you.
Thank you to all panelists.
Dr. Mathur.
Thank you very much.
Thank you.
Yeah.
Thank you so much. Good night.
Good night, everyone.
Good night. Good night. Thank you. Thank you.
Good night.
Very aggressive 4 sessions today. Dr. Bharat, you are still evergreen.
Thank you, sir. Thank you, sir.
Evergreen.
Wonderful being here, sir. Thank you very much.
Okay. Okay.
Thank you, sir, for all your inputs and I think clearing most of the doubts.
Yeah. We are looking forward to further association in future, the IAPM Kerala chapter. Okay. So thank you very much. I think we can, it's time to leave the webinar, and good night, everybody. Okay.
Good night, sir.